All right, folks. Can y'all hear me? Nope. Volume up. Can y'all hear me now? Let's go down. How about that? Is that better? Got to get the volume right. Well, good morning. Thank y'all for being here. And we're going to begin. Apologize, we're starting a little late. We're trying to make sure all our members get here. We're missing a couple in traffic who have texted and are on the way. And so we're going to go ahead and begin. We're here today. We're going to go to Representative Hawkins. We're here today to begin discussing, H.R. 141. I do want to remind everybody that of some things that might be interesting to you, and we have the departments here as well. Just to be clear, so we spend, and this conversation today is not just about Medicaid, it's about long-term care in totality. We wanted it to be kind of broad, so whether it's private sector, whether it's Medicare, whether it's Medicaid, it doesn't matter. But since obviously we're a state legislature, it might be interesting to just remind everybody that we spend about $13 billion a year on Medicaid in this state. And in that age-blind and disabled population that we're here to talk about today, a lot of people are not aware. I think it's very profound to note that 57%, 56 to 57% of the dollars we spend on age-blind and disabled go to 25% of that population. Did y'all know that? Most of the folks in this room probably do. So 25% of that population consume 57% of those funds. And so that's those folks that are most in need, which are the folks that we're talking about today. And so, Chairman Hawkins, H.R. 141.
Thank you, sir. I'd like to thank all the folks that are attending here today. A lot of familiar faces and old friends. I think we're all very interested in this subject, and that we all hope we get to a place where we have gray hair and trying to figure out what our next step is, rather than the alternative. We're looking at different programs and different models and different ways to fit a population that thinks that way too, that different things fit for them. And I think forward-looking, we look at all the possibilities and help support that. There are people who would like to stay in their home with more assistance coming into the home. They deserve some help too. Obviously, we have people going into the nursing homes, extended care, and that type of thing. And there's a number of approaches out there. Back when I was in the Senate, I worked with Johnny Isaacson and his son Kevin on one that they developed in Cobb County that became very successful. As the chairman noted, age-blind disabled is heavily funded toward the senior, but that's normal. If you look at healthcare outside of government, it is the same. Healthcare gets much more expensive toward the end years of life. We're dealing with kidney and liver, heart problems, respiration problems, more incidence of diabetes and cancer and a number of other things. So, yeah, we spend more dollars there. Right now, the ABD is a fee-for-service, and I'm going to always support that. I think that's a much more viable option for a very a group of folks that really need help. I think that's a viable group. So anyway, I'm going to hush up and let y'all begin. I know it's going to be a long morning, and again, thank you all for coming. I may have to leave a little bit early. I've been working with the cardiologist on some legislation, another thing to try to keep us all alive a little bit longer. So thank y'all.
Thank you, Chairman Hawkins. Okay, let's begin. Let's get right in. We've got a lot of folks want to speak today. I know we have some, I just want to mention we have a sign-up sheet out front. I think we have some additions to the agenda that was posted. That's good. That's a good thing. We want to hear from everybody. Chairman Hawkins' goal from the outset, as he just stated, we need ideas. We want to discover any and all ideas that our members can note and carry forward that may be better and innovative ways to serve people in long-term care. And so we're going to begin with Ms. Deborah Stokes. Jump right into this agenda. Ms. Stokes, the floor is yours.
Thank you. Good morning, Chairman Petrie and committee members. We appreciate the opportunity to be able to present to this House Human Relations and Aging Committee. As you know, my name is Deborah Stokes, and I serve as Executive Director of the Georgia Council on Aging. Since 1977, the Council on Aging has had the privilege and the responsibility to serve as trusted advisors to the governor, the General Assembly, and state agency leadership on issues affecting our aging population. The affordability and accessibility of quality health care, housing, food, transportation, mental health services and dementia care, broadband access for telemedicine, and caregiver support are among our key areas of concern. We are grateful to have some of our most respected partners here today who have for decades consistently stood alongside us as we work to support our singular mission to provide for the needs of our seniors in this state. For several years, one COAGE priority has been to expand options for the quality long-term care to serve Georgia's older adults, including disabled and at-risk segments of that population. During the 2021 legislative session, as Representative Hawkins mentioned, he sponsored H.R. 141, which was designed to take an organized look at innovative options and models of care that focus on the person, from the more home-like architecture of buildings to staffing models that not only create efficiency in the delivery of personal patient care, but are also designed to improve workforce retention through employee satisfaction, to even creating financial and financing options designed to help forward-thinking providers pay for this extended care. As often happens, this research expanded into other opportunities to improve the entire continuum of care for Georgia's older seniors. The growth of the aging population in our state has become an oft-repeated statistic. Georgians aged 60 and older currently represent more than 15% of the state's total population. The senior population will expand by over 500,000 people between now and 2030. By 2040, the number of Georgians who are 75 or older is projected to increase by 47%. Georgia wants to continue to improve the delivery of quality health care for all of its citizens. That's why we're here today. To provide an overview of the material presented by the Georgia Council on Aging, it's in your member packets, I'd like to introduce former two-term chair of the Georgia Council on Aging, Ms. Vicki Johnson.
Thank you, Deborah. Good morning, committee members, and thank you, Mr. Chairman, for allowing this conversation this morning. We know that it's been a topic of great interest for 6 years, starting in this committee in 2019 with the study committee that Chairman LaHood chaired that year and had many recommendations. So we have formed a work group within COAGE. COAGE is the Coalition of Advocates for Georgia's Elderly. And this work group has brought together stakeholders on the subject of long-term care for older adults. Over the 6 years, we have been researching various options. We have been looking at national studies. We have been looking at Georgia-specific material. And we have tried to distill that down to some documents in your packet today that we think might be helpful as a way to move through the thought process on looking at new options for senior care. The first item would be the H.R. 141 itself from its sponsor, Lee Hawkins, and this is as it was amended in your committee in March. Then we have a projection that Deborah Stokes made reference to of the aging population. This material comes from OPB, and it shows that by 2029, the older population, age 60 plus, will outnumber the population that's under age 20. Mary Lee Boatwright Quinn, the Director of Division of Aging Services, will be able to share more information with you this morning about the services that are being provided to this senior group by DHS. We then have a table that shows the categories of long-term care in the state of Georgia, and you'll see that some of these do participate in Medicaid, but others do not. And we pulled numbers from DCH as to the number of bed slots that are authorized by category. And where we have information available, we have put that in the table. And you'll also see at the bottom that we have information about those receiving non-Medicaid services in their homes. Then you have some maps. These maps were drawn by the Atlanta Regional Commission staff, and what they depict is the location of 3 categories of assisted living and personal care home facilities. The one map shows the personal care homes of less than 25 beds, because in Georgia we divide personal care home into 2 categories: beds 3 through 24 and beds 25 and more. The smaller units can participate in Medicaid. The larger units are, by rules and regulations from DCH and the waiver contract, not authorized to participate in Medicaid. And then we have a map, and in each map, you'll see the location of the facilities, and you'll also see by shading the percentage of residents age 60 plus who are in low-income categories. And so when you look at these maps, you will see that there are many rural counties in Georgia with very limited long-term care facilities. We have a map also in there of assisted living. Assisted living is a separate category in Georgia. It has a minimum bed number of 25, and assisted living facilities by statute are not allowed to participate in Medicaid. You will have material from A.G. Rhodes on the new facility, and you're going to be hearing from Deke Cato shortly, and he's going to be able to share with you the exciting news about the new model nursing home that A.G. Rhodes is constructing now in Cobb County. The Georgia Alzheimer's statistics is also in your packet, and that shows you the count and the severity of Alzheimer's disease in the Georgia profile. In your packet also is a copy of HB 582, which is the 2023 bill sponsored by Chairman Sharon Cooper, and this bill would change the restrictions on Medicaid enrollment in assisted living and personal care homes. Tom Bauer from Leading Age will be speaking with you about that and that initiative, and Terry Barcroft is here today from Wesley Woods, which is a Leading Age member, and she'll be able to share with you information about who would benefit if we can make some changes in Georgia. Switching to nursing homes then, there is a projection of 2025 nursing home bed needs. This comes from the Department of Community Health. This is the formula they use to project the number of beds of skilled nursing homes that are needed in each of the 12 regions of service in the state. And in thinking about 2025 needs, you'll see that in 6 of the 12 regions, they are projecting deficits of nursing home beds. The 6 regions are all in North Georgia, plus the area of coastal Georgia in the Savannah area. You'll see the map following to show you those service areas. In 2022, CMS issued a bulletin which encourages states to increase a reimbursement rate for private rooms in nursing homes. It's been thought that you could not have a private room in Medicaid programs, but here is the bulletin that shows that CMS recognizes the value of private rooms, particularly in working against the spread of pandemics, such as we had with COVID-19. And so they have asked the states to consider increasing the reimbursement rates for private rooms. There is an article, Big Idea Behind Small Nursing Homes, and this gives more information about the AG Roads project in Cobb County. There is a white paper from the National Center for Assisted Living. This is a 2023 white paper with an overview of the national picture about assisted living. The summary is that there is a growing population, which means a growing need for service. There are declining numbers of caregivers who can help people remain in their homes independently, and the costs of care are rising. So when you take these 3 factors together, it indicates that states should look to alternative sources of funding beyond what is being used currently. And for example, Medicaid. There is a booklet from the Georgia Health Policy Center, Improving Access to Medicaid HCBS. This is a summary of a presentation that was made at the Georgia Gerontology Society conference this summer. And it has good information about the federal effort to rebalance Medicaid spending in the states so that it goes more and more into home and community-based services rather than institutional care. Now, there are other speakers on the agenda, but this is the information that the Georgia Council on Aging COAGE work group has put together. It's a small part of what we've been looking at, but I think that it provides enough salient points for the discussion that I hope that it will be helpful for you. And we're also expecting Marcy Alter from Health Management Associates to be with us today. I don't see Marcy yet, but she has material on their white paper on the subject of a national look at what's happening with Medicaid in the states. So thank you, and we appreciate the opportunity to participate, and we want to remind you that the Georgia Council on Aging is a resource for policymakers, so please call on us if we can be helpful or if you have concerns. Thank you.
Ms. Stokes, stand by in case we have any questions. I do want to mention a couple of things just to, as you know, and I think most everyone here knows, I spent my entire career in long-term care. So I will tell you, I think we should note that you mentioned home and community-based services and rebalancing. continue to be our goals, but the state has done, I think, come a long way. I remember back 30 years ago, well over 30 years ago, when I started in this world, and almost everyone was institutionalized, you know. And so we've come a long way, and I think we all recognize the value of our institutional services and the value of home community-based services, but we still got, you know, a ways to go, but I think the state has done a remarkable job there and needs to continue to do more. I do want to also mention, I want to tell you, this is great information, and I think it's excellent. We got homework now. We got plenty to read, don't we? But you might want to note that, as I looked at this, it's important that we note that about 73% of skilled nursing beds, and I know you showed us those beds, and kind of where there's a dearth of beds, about 72% of nursing home beds are paid for by Medicaid, just so everyone here is aware on the committee. And so, any questions for Ms. Johnson or Ms. Stokes? Any questions of our members? All right. Seeing none, we'll go to Ms. Boatwright Quinn with Department of Human Services.
Good morning. And I think, Ms. Holloman, if she's here, I had a PowerPoint. Is it loaded up here? Does anybody know? If not, I have it for you. If you wanna. Sorry, I don't see a. To see my.
And Mary Lee, if you would just, everyone before you present, just remind everyone who you are and who you represent. I think that'll be helpful to the committee.
Absolutely. Let me just get set technology-wise. All right. That was pretty good. Hopefully I can move the slides. I can. All right, great. Good morning, Chairman Petrie, members of the committee. It's great to see you all this morning. Thank you for the opportunity to speak. I'm Mary Lee Boatwright Quinn. I'm the Assistant Deputy Commissioner of the Department of Human Services Division of Aging Services. And I'm going to tell you today what exactly that means, what our purview is, and where we fit into this discussion. So I'm going to, as Deborah mentioned and Vicki, they gave you kind of some of the demographic information that I would typically share, but I'm going to go straight into, what is home and community-based services, how are we funded, and why it's important that we look at expanding options across the long-term services and supports continuum. So those of you who might be new to the committee or new to this work, we use the term LTSS, that's long-term services and supports. And think of that as a continuum from home and community-based services all the way to institutionalized care. There's a continuum there. And we sit on that far end of the community services continuum in terms of the services that we administer through our agency. So most of you know that our department vision is Stronger Families for a Stronger Georgia. And our vision of living longer, living safely, and living well fits very nicely into that. I see this as us developing communities where all can live and age in place well and safely. So I always find it helpful to share with you all, how the funds and the regulations come down to us. The Older Americans Act that was passed in the 60s basically created these home and community-based services and that were non-Medicaid, I will say. So HHS is the upper body, the federal agency that houses the Administration for Community Living. And then the Administration for Community Living, or ACL, actually designates us at the Division of Aging Services as the state unit on aging. And as that state unit on aging, we administer funds down to the local or regional level through our area agencies on aging. So you can see that here. And then our area agencies on aging, they contract with those funds for local service providers. So that's kind of the flow. And then you will see, obviously, that the legislature, you all impact us as well because you add additional state funds and laws and regs in there for us to comply with. I thought it would be helpful. Oh, and I did mention here, you see Vicki and Deborah talked about COAGE, and they definitely are our advocacy arm, if you will, and advocate for all of those funds and legislation to support the work that we do. So I have this for state fiscal year 23. My apologies, the FY24 one just came out, and I didn't get my hands on it before today. But this at least gives you a nice snapshot of the Department of Human Services and where we sit. So the DHS has about $1.8 billion allocated to protect and serve Georgia's vulnerable populations. And as you can see, we are that kind of purple 5.6% slice there. And we are serving the older adult population. And so as of last year, we had $113.6 million state-funded budget. So as I mentioned, we allocate funds, both state and federal, down to our Aging and Disability Resource Network, and that is our area agencies on aging. We have 12 AAAs, we call them, and 10 are housed in regional commissions and 2 are nonprofits. I did want to mention that although they are closely aligned with the regional commissions, they don't exactly match the boundaries any longer. All right. So what are home and community-based services? As I mentioned, we're on the beginning of that LTSS continuum. So we are, again, trying to help people age in place, stay in their home of choice, and avoid institutionalization as long as possible. And some of these are Older Americans Act services. Most of them are. And sometimes we have individual AAAs that get creative and add additional innovative services, and I'm going to talk about those in just a moment. But some of the examples of our home and community-based services are what you see listed here. So in-home services like personal care assistance and home modification, for example, as well as case management and then caregiving supports, everything from respite care to caregiver training, for example. And then, of course, a huge part of our budget is nutrition and wellness. Those are our Title III programs that are for home-delivered and congregate meals. And as well as part of the nutrition and wellness, we do evidence-based chronic disease management. I did want to also mention that we work in a joint initiative, basically, with DCH and DBHDD to transition Georgians residing in institutionalized settings who can go back home with certain supports. We have the Money Follows the Person program and Options Counseling, which is nursing home, basically helping people get out of nursing homes that have expressed an interest, but then also after a thorough evaluation, we recognize that we can transition them back into the community. So, and our AAAs also serve as, I'll say, the gateway to our Medicaid waiver programs through our ADRC network, because they are the level 1 assessment providers to those Medicaid waiver programs. And I'm sure that Brian Dowd is going to tell you more about those, so I won't go into detail there. When I saw the topic of our committee meeting, it was timely because I was just last month at a conference where some new data was shared from the U.S. Aging. And U.S. Aging is basically the association for the area agencies on aging nationally. And this survey was just released last month. And it's about housing and homeless programs and partnerships, and how our AAAs impact or are receiving requests for housing assistance. And you'll see here that, so this is a survey of all of the AAAs across the country. And you will see that the top 5 housing challenges facing older adults per our area agencies on aging, the first one is lack of affordable housing. 85% of our AAAs said that was the number one. And then there was also the unavailability or long wait list for subsidized housing or housing vouchers. That was 71%. And then as well, increasing rents, which basically price some older adults on a fixed income, out of housing. In addition, there was 63% that reported lack of accessible housing. So as we know, a lot of our older adults that we're serving have one or more disabilities, and that makes it more difficult for them to stay in their homes if the home is not accessible to their level of ability. Included in this survey were also the top 10 related services that our AAAs provide, and this is true for our AAAs in Georgia as well. Here it says that 81% of AAAs nationally provide one or more programs that really assist with housing. In Georgia, that it's 100%, because the number one thing on the list there is home modification program. All of our AAAs have funding for that, and also try to get creative to increase that funding, because I think, as you'll hear from some other speakers, this is a huge issue. If you have a senior who is on a fixed income and their roof starts to leak and they can't repair it, then over time, this obviously becomes an issue where they're not going to be able to remain in their home. And that's just one example. There's a lot of various home modifications that can happen through our AAA network. I also wanted to mention here a creative initiative by our Atlanta Regional Commission. They have a project called Live Beyond Our Expectations, and it's to address inequities that create disparities in life expectancy across the metro counties. And when they did their basically getting feedback across the counties, in 7 out of the 10 counties, affordable housing was noted as the top issue for older adults to age in place. These are just some examples that the AAAs in this survey noted as potential partners for addressing housing concerns. And I would say that we aren't, I think these are informal partnerships that we could work to formalize some better partnering across some of these types of agencies. For example, city, county, and local housing offices, legal support for tenants' rights. We, of course, have an elderly legal assistance program, and honestly, that is an issue that she assists people, and our ELAP program across the state assist people with those tenant right issues. And of course, Centers for Independent Living, we already work closely with, but other home repair programs, for example, like Rebuilding Together and Habitat for Humanity. I think we do have some opportunity here in Georgia to expand some of these partnerships to address the housing shortage, if you will. So another data point that came out at the recent conference was about our elder care locator line, and that basically our Aging and Disability Resource Connection is our local entree to all of the home and community-based services. An elder care locator is a national line, and typically they would then refer down to our local AAAs as well if somebody got to that number first. But they recently shared some of the shifts in what they see people calling for assistance for. So I wanted to share this dashboard with you because it shows here that the top 3 issues are really in that long-term services and supports continuum. In-home services, transportation, and housing options. So you can see that that's over 50% of the calls are calling about long-term services and supports and need for assistance. And then I also thought this data was interesting to share with you. There's been a shift from 2012 to 2022 of the reasons for calls. There's been a huge increase in calls, and that's the same for our Aging and Disability Resource Connection. But you can see here that transportation has remained the number 1, but you see that housing moved up to the number 3, and then long-term care actually showed up in the top 5 in the last 10 years. So there's obviously the demand is being seen. And then I decided to pull for us our top reasons for calls to the Georgia ADRC, which is our, again, Aging and Disability Resource Connection. It's our entry point for folks to find out if they're eligible for home and community-based services. And I will tell you, I learned that we have some shoring up to do both in our training and our categories because our number 1 was not indicated, so we've got to work on that. But I did, and I think what we're going to do is now align our categories because we had too many with those national categories so that I can start giving you a comparison of apples to apples. But I did want to share that even with that, EDWP, which is the Elderly Disabled Waiver Programs, is in the top, and it's one of the highest reasons that people call our ADRC, which again, it means that they're in need of assistance with activities of daily living or IADLs. And then I wanted to share too, in that right chart is actually that the top 10 reasons we have actually covers 85% of our calls. So as I close, I just wanted to ensure that I express just my opinion from my knowledge of being a social worker in this field. For many years, I worked in home and community-based services as a direct social worker back in the early 90s, then went to policy and then now at administration of these services. But it's clear that we need to have more options across that continuum that I described to you because there is not a one-size-fits-all. And we are more efficient and effective with our resources, and I think more effective with the people we serve, if we can give them more options across that continuum. And so I think you're going to be hearing some about those creative innovations from our next few speakers. But the other thing I wanted to mention is you're seeing a trend that CMS, through Medicare, is recognizing that these home and community-based services impact somebody's health, and they reduce healthcare costs by reducing hospitalizations, by getting somebody to be more compliant with their chronic disease management. And so we can do those things through home and community-based services and avoiding the more expensive services if we can drive resources there and also, again, create some innovative approaches across that continuum. And that is all for me, Chairman Petrie. If anybody has any questions, I'm happy to entertain them.
Thank you. Any questions for Ms. Quinn from the members? All right. Yes, we'll get the.
Yes,
we'll get Bailey to get
make sure that you have the slides. Thank you.
to get the slides. We do have. Okay, Representative Cannon. Question?
Thank you, Mr. Chair. Thank you for your presentation. I know that we are here on a very limited subject, but of course, we're also undergoing Medicaid redetermination, which is severely impacting our constituents, and we're working with nursing homes. We're trying our best as legislators. Just wanted to see if there was anything related to how that process is going, because we're hearing numbers that people are being left behind. Thank you.
Yeah. That, I'll be honest, is more in another part of DHS, but we have been diligently working with them to ensure that we get the word out to our population about, how to make sure that you're contact information is updated and that you don't miss your opportunity to be reassessed for Medicaid. And so we've been working closely with External Affairs to make sure that the audiences we serve are getting that information. But I'm not sure if anybody else from DH is going to be talking about that today. Do you all know? I don't think so. So I will make sure that one of our team follows up with you.
Representative Campbell.
Thank you, Chairman. Thank you, Mrs. Boatwright, for the information. Would love to get the deck. My question is similar to Representative Cannon's related to the call numbers that you mentioned.
Yes.
Can you tell a little bit about how does our aging population know about these services? How do we communicate who to call, when to call for either Medicaid-related issues or any of the issues that you talked about?
Yes. We do market our Aging and Disability Resource Connection line. As well, our AAAs do reach out in their region to market that line, that 1-866-55-AGING. And on that line, folks can find access to local resources, those non-Medicaid home and community-based services, but they can also get access to our Medicare SHIP program. So for assistance there, you can pretty much reach every part of my department through that line. So that's the line that we most often drive people to, 1-866-55-AGING.
I was just curious to know.
Okay. Wait.
If you could expand just a little, I'm very curious to know, how do you get that information out about the phone number? Is there a mailer that goes out to all Georgia residents, 60
Yeah.
older, or?
It's through a number of media. I rely on our communications team for that, but through earned media as well as through mailers for our Medicare SHIP program, for example, our website. I think that we're always looking for new creative ways to get the word out. So if you have suggestions, we're certainly open to them.
Representative Scott.
Thank you also for being here, and thank you to the chairman for having this meeting. I guess I'll fall on the line with Representative Cannon and Campbell. Now with the SNAP issue that we're having, trying to get people to fill out the information. Well, a lot of seniors going to be involved in this also. I guess I'm asking the same question. Are you all communicating with all of the seniors in your facilities or group to get this information, because its deadlines are approaching real fast?
Yes. Many of our AAAs actually work with, they provide access to filling out those SNAP benefit forms at their local senior center. And so that's the primary way I would say that we are assisting through our AAA network with that application process.
Is it a number for your AAA access?
Yes, 1-866
Okay.
55-AGING.
Okay.
Representative Okoye.
Thank you, Mr. Chairman. And your department is doing a great job. But it's also important that the people you are serving know about the opportunities to help themselves. Can you get into a partnership with representatives? Because we get down to our constituencies.
Yes.
And information that you need to get out should also
Thank you.
come
Yes.
to us.
We are actually going to be presenting to the constituent services reps in the new program soon. So we do that every year. But you bring up a good point. We should make sure throughout the year that your constituent services reps have that information, not just right before the session.
And if I could just add, I'm Jackie Tate with the Department of Human Services. We have an outreach team, and we also have an outreach mailbox that any of you are welcome to request a presentation to any audience that you think would benefit from our information. Emma, if you could provide the Outlook mailbox But we have that information available on our website. And again, we will be presenting to the legislative aides, and we'll make sure that we include that outreach mailbox in that presentation so that you know that you're welcome to reach out to us and request presentations at any time. And if I could just add to Representative Cannon's inquiry, a lot of the elderly population, their income doesn't change, their circumstances don't change, so we'll be able to renew a lot of those Medicaid cases through an automated process because we have access to their income information through the Social Security Administration. So we are doing outreach. We are also checking whatever information systems that are available to be able to just make that determination and automatically renew them. That's helpful.
Well, thank you, and to all the members. Is there a follow-up question? Representative, I'm sorry, I didn't see that till now.
Follow-up statement,
Quick
because I
question.
mean, we're getting numbers that are showing the number of people who have not been able to be, you know, who have not been able to be redetermined to get their services. So I'm just looking for numbers, facts, resources, exact information about how our constituents are being redetermined, because we're hearing that they're facing rejection.
All right, I just want to mention everybody, by the way, to some of the questions. Miss Jackie Tate there is phenomenally helpful. If you need help for your constituent, she has always been a tremendous resource to me. Okay, so here's the deal. We have those two first presentations are foundational. I think there's a lot of good information about kind of services kind of in general. Now we're going to get into the real intent here, which is talk about different ideas. And so we have Mr. Cato. Did I pronounce that right, my friend?
It's okay, Cato.
How
but
close?
that's
Well,
okay.
I'm a guy that gets my name mispronounced
That's
all the time,
okay.
so I want to get it right. You tell, when you introduce yourself, you teach me how to do it right.
That is okay. There we go. Thank you very much, Mr. Chairman and esteemed members. My name is Deke Cato, sometimes called Cato, and I'm the CEO of AG Roads. AG Roads is one of Atlanta's longest-serving nonprofit organizations, and I'm proudly here today to speak a little bit about some innovation that we have in our industry. I know when we hear about nursing homes, especially recently, most of what is evoked is not positive. Mostly you get negative thoughts when you do. So I think a little bit of what I'm going to speak about first is the history of AG Roads, which for me, we cannot understand innovation, we cannot understand the future and where we're going if we don't understand where we have come from. And sadly, the history of nursing homes comes from a kind of negative past. My organization, which is one of the top organizations in the state, was 120 years old, was originally called the Home for the Incurables. And that was not, those types of names were not, dissimilar. That's what nursing homes came from. We came from a history of poorhouses. We came from a history of almshouses. We, though, are happy to have innovated so much in the past and continue to innovate. My organization was one of the first to have an electronic medical record, even before it was required by the Affordable Care Act. We continue to innovate through technologies, and most recently our project at Cobb, which I will speak to in a minute. We consist of 3 nursing homes. The original flagship location built 120 years ago at the same location in Atlanta, right off the Zoo exit, Boulevard exit. Then we also have a second location, Cobb, that we opened in '92, and in 1997, our AG Roads Wesley Woods campus opened on Emory's Wesley Woods campus. We proudly serve about 1,100 seniors each year. I want to point out this number. Prior to COVID, this number was about 1,500 individuals per year. And for the last 3 years, we have for obvious reasons, had a dip in our occupancy. Our occupancy rate now runs about 84%. Prior to COVID, that was 95%. And for those of you who would not understand, that is mainly because of the need now to isolate individuals who live in shared rooms when they do contract COVID. We are proudly serving not only Medicare but Medicaid residents. The chairman's statistics earlier is absolutely correct. Per our industry and per our organization, our Atlanta home in particular serves 90% Medicaid residents. So let's talk a little bit about that innovation. Nursing homes as we know it, historically, long hallways, very sterile environments. Most nursing homes were built in the 60s and 70s and actually built to be hospital and hospital-like environments through the Hill-Burton Act of the 60s. So nursing homes were incentivized to build these sterile type environments. What happened, particularly during COVID, I think brought huge focus on the need to change how these environments lived. Unfortunately, hundreds of thousands of individuals died during COVID. Even us at AG Rhodes had way too many deaths than we would want. We had way too many people contract COVID. And the way I depict it, COVID literally was like a wildfire in our nursing homes. It was, once it got in, it was impossible to get it out, and it spread, and it spread exponentially, and it spread very quickly. One of the big reasons for that is the abundance of semi-private rooms in our nursing homes. The AG Rhodes nursing home that I ran back in 2009, we actually had, and some nursing homes still have ward rooms. And a ward room is a room that has more than 2 individuals, some 3, some 4. Thankfully, we were able to make changes as a nonprofit organization, but many of our state's nursing homes have not and cannot make some of those changes. So what we try to do with this new project is have a completely new nursing home layout. Instead of these long hallways and these ward rooms, we have private rooms. Whenever I speak about this, I typically poll individuals as to who would like to live in a room with 1 or 2 or 3 other individuals if they had to live in a nursing home, and no one's hands goes up. So we have moved away from that in our new construction, and we have built what we call households of 12 residents, each in their own private room. Our CARD project has 6 of these households, totaling 72 residents. These rooms are earmarked, again, from one of the statistics I heard earlier, for individuals living with dementia, specifically for individuals living with dementia. What we have seen in our nursing homes is about 70% of those that we care for now are living with dementia and some sort of cognitive illness. So from our perspective at AG Rhodes, these are the most vulnerable of the already vulnerable residents that we care for. Mr. Chairman, this project also, in addition to seeking to stop the spread of infection by having private rooms, we also want to honor the dignity of the living and the aged experience of our elders. We think, again, that people should have the right to make that choice if they choose to live in a private room or not, whether or not they're on Medicaid. Those of you who know AG Rhodes would know that you walk into our homes and you are not going to know the difference between who's on Medicaid, who's a Medicare resident, and who's a private pay resident. And that's the dignity of living that we think everyone deserves as they age. Thirdly, very importantly, we want this project to strengthen our philosophy on person-directed care. In 2015, we made a trip to the Netherlands where we experienced a different type of care, a care for elders that was based less on the staff's needs and requirements and less on efficiency and more on the needs and the requirements of the elder, of the resident. And that sparked a total revolution for us. You would notice the language that I use, elders, not patients. And a lot of that is that person-directed approach. It is very difficult to do that approach in the current design of nursing homes. Lastly, we want this project to serve as a replicable model, not just for the state of Georgia. I proudly serve on several national organizations, national committees one of which the Moving Forward Committee is charged with changing or reforming nursing homes, if that is at all possible. And we have offered this up also as a model that is replicable. We think it is possible. We think the state of Georgia has the ability to take the lead in that, as we are. I will note it is not an inexpensive project. This project has cost us about $33.5 million, about $14 million of which we were able to raise through fundraising and through federal new market tax credits. So I tell folks this is a great nation, and we are able to build stadiums, highways, hospitals through public-private partnerships. And I think we owe that to what is soon to be our largest segment of our population and our most vulnerable. So I will end by, if technology allows me to, showing a quick little video. And this video is basically a collage of our project, which started last July, is 80% completed, and we hope to open in the fall. Thank you very much, Mr. Chairman.
Thank you, Mr. Cato. That was excellent. Excellent. And those are the ideas we're talking about. Well, I have a few questions. I think we're going to have several questions. I have a few for you first. So very, very interesting. So first of all, we talked. You spoke about vacancy post-pandemic. So I want to ask you a question. How much of that vacancy is related to labor shortages and how much is related to the pandemic? Because I understand well, having been in this industry for a long time, not any longer, but having spent a long time in it, that right now labor is the chief issue with all providers. So help me to help us to separate that out.
Yeah, it's a great
for
question.
your organization.
Yeah, it's a great question. For my organization, almost all of that was due to the isolation.
To the what, sir? I'm sorry.
The isolation of residents.
Isolation.
So it's because directly of COVID. I will say, though, that my board, as a nonprofit board, made the conscious decision to continue admitting residents, even with the shortage of labor. We have had to rely extremely highly on contract labor that we would not have used before. In fact, we've started our own contract agency because of it, and it's at a huge cost to do so. I don't know how long we would continue to be able to do so, because you're very correct. The labor shortage is a real issue.
Thank you. And a follow-up question. So on your, very interesting, your private rooms, currently, how many of your new model, your person-centered model and your smaller facility, how many of those beds are serving Medicaid individuals?
In our current version,
Yes,
over
currently.
70% as an organization of our beds are serving Medicaid.
Right, in the aggregate, but even in the new model?
Yes,
Okay,
even
gotcha.
the new model.
And so, obviously, there's a huge cost difference.
Yeah.
And I was talking to, there's some architects here today that I'm known for a long time that were talking to me earlier about the cost of,
Yeah.
additional costs today that are incurred.
Yeah.
So obviously, you're talking about, and you mentioned the $33.5 million, building project. So help me to understand the difference between your private pay rooms and your semi-private rooms.
Yeah, so that's the issue in the new model, is that the private differentials that we would have previously got are going away, because there's no option, right? You don't have another option.
Right.
Thankfully, again, as a nonprofit, we have the ability to fundraise to help the gap of some of those costs. I'll also admit that AG Roads is at the higher end of Georgia Medicaid reimbursement, and it's because we've continued to make improvements on our building and Georgia Medicaid fair rental value system that has been put in place.
And for our committee to know, sir, what is the current rate? What is your current rate you just alluded to on Medicaid?
It differs per home. I would say on average now about $320 a day.
So $320 a day,
Yeah.
which is much higher than the state average.
Yes.
Much higher, because the state average currently 220 something. Let me look. I'm going to look it up for our members. I think this is important. The current Medicaid rate per diem statewide average 224, 224.67 for our members. Please write that down. That is the Medicaid average daily rate inpatient days.
Yep.
And 75%, it looks like, statewide were on Medicaid. A little more than I alluded to earlier. Okay, so obviously you're getting a much higher rate,
Yeah.
but you are providing people with,
A much higher level
in
of-
these new facilities
Yes,
with the
absolutely.
private rooms. Okay, very helpful. All right, more questions from our members? Chairman LaHood.
Hey, thank you for your presentation,
Thank you,
and
Mr.
I've always known you to have great respect in the industry and do a really good job taking care of seniors in need. A couple of questions. One's a follow-up to Chairman Petrie's on the labor. Recently we've heard of this pending new staffing rule that's going to increase the staffing requirement in skilled nursing environments. How do you see that impacting your operation?
Gravely. So I'll just say for the record that I do not know of a provider who does not want more staffing, right? We all want more staffing. The issue is that we don't have the staff is not there. The other issue is how do we pay for the increase in staffing? In particularly, and those of you in the room who understand this, particularly in the case of those individuals living with dementia, statistics show that less of a pharmacological approach is what individuals with dementia need. Less medications, more direct care. My biggest issue with the staffing mandate and the RN requirement is that is in antithesis to the type of care that we give. I want, in my nursing homes, more care closest to the resident. No disrespect to nurses. I serve on Georgia's Nursing Education Council, so no disrespect to them at all. However, that is care that is a bit further from the direct resident. So I have huge issues with the mandate because of that. In addition to, I don't know how we can staff 24-hour RNs in the current environment.
Correct. And it's known that there's approximately 28,000 open nursing positions in our state now. And so increasing that requirement for more nursing presence is only setting up providers for
Failure.
noncompliance.
Yes.
And also with direct caregivers, I know there's a shortage of direct caregivers as well.
Yes.
It's documented that there's approximately 200,000 fewer CNAs, certified nurses assistants, working in the skilled nursing arena than today compared to 2020,
Yes,
February of
absolutely.
2020, and I believe it's almost 500,000 caregivers nationally, of all types, not just certified nurses aides, but direct caregivers. There's that many fewer working in the profession
Yep.
as caregivers than compared to pre-pandemic.
Yes.
And so we're faced with a severe labor shortage. So I think efficiency, investing, in technologies,
New models, technologies.
building designs, different areas that can provide efficiency and make providing care more efficient. So in closing, and one more question, with your experience and expertise in this field, what policy recommendations do you have for us today?
It may seem as a selfish one, but I absolutely do point in the direction of a CMS recommendation of incentives for providers to do things like this. I don't think I think if it's not incentivized, it's not going to be done. I think there's a role for technology to play, not in caring for individuals. That's a real touchy subject now. But I think in being assistive to allow residents to care for them. I think there's a role for medication aids in nursing homes in a more pronounced way, in providing some of that medication administration if and when it is needed. And I would just point as well to, I think in many ways, and I understand why, but in many ways we are a highly over-regulated sector of healthcare. There's no reason that the burden on nursing home regulations should be higher than hospitals, should be higher than assisted livings, and it is. It is. So you could go into a lot of these environments still maskless, right? And nursing homes, we have that much higher burden on us. So I think those are just three solid policy things that we can and should look at, not just as a state, but as a nation as well.
Thank you, Chairman LaHood. Mr. Cato, I want to follow up to your comment, because we're here to learn, about medication aids. So we have addressed in this body and passed legislation to allow more fully medication aids in nursing homes. Help us to understand what more we could do. That was one of Chairman LaHood's priorities. So help us to understand what more we could do there.
And maybe I should have phrased it, staffing improvements like medication aids. A good example would be infection requirements now nursing homes requiring infection control nurses. I mean, a lot of these roles I think may be able to be done by a LPN or by even let's say a CNA that we train up through lattice arrangements to become that. So I just think we have to get innovative in our staffing models and less restrictive. And Congressman LaHood, I do thank you because I know your role and your involvement in bringing that forward. And it's a touchy topic. We have about 3 right now in the AGO's organization, and it's working.
Excellent. Thank you, sir. Any other questions from the committee? All right.
Thank you.
I believe that's all. Thank you, Mr. Cato. All right, Mr. Dowd. Brian Dowd is up next with the Department of Community Health and others, and Grant Thomas. All right. We got a bonus today. We get both of you guys and Miss Sylvan over there. Thank y'all for being here, and thank y'all for the help you always provide. Any information I need, y'all are always there with it, and I appreciate y'all. I was interested to see when on the agenda we saw PACE, because way back in the day, I was one of the earliest providers for the new innovative SOURCE program that at the time was a new thing, and now we've had SOURCE in this state for many years now, and it was really built around a model similar to PACE, but I know you'll tell us more about that. Mr. Dowd, thank you for being here. Floor is yours.
Great. Good morning, Chairman Petrie and members of the committee. Thank you for the opportunity to be with you here today. My name is Grant Thomas. I serve as Deputy Commissioner at the Department of Community Health, And today I'm joined by Brian Dowd, who serves as our Deputy Executive Director of Medical Assistance Plans with purview over the Medicaid and Peach Care programs in the state. And we also have Brandy Sylvan, our Director of Government Relations, here as well. Before we get into the presentation on PACE, I did want to take a moment to just inform committee members and remind committee members about a process that we have underway at the Department for Medicaid provider revalidations. Per federal regulations, all state Medicaid agencies are required to update information that in our system on providers every 5 years. This requires providers to go into our Medicaid Management Information System, GAMIS, and complete a short questionnaire that includes information related to their contact information, demographic information. The entire process takes about 20 minutes to complete, so it's a relatively straightforward process. We have to do this, like I said, every 5 years, and there were some extensions during the PHE, but it is now time that we have to do this per CMS guidelines. We've done a lot of outreach, including direct mailings and contacting providers. We've reached out to a lot of the provider associations to make sure that they're aware of the process and sharing information with their providers. And we've also done banner messages in the Medicaid information system. But any help you all can provide with just any providers you know, or if any providers reach out to you with questions about how to revalidate or how to complete this process, we feel like we've made it very straightforward and have put a lot of resources out there, but we are happy to assist them further. And please feel free to send them our way, and we will help make sure that they're able to complete that process so that they continue as Medicaid providers. Like I said, we greatly appreciate the opportunity to be with you here today to discuss PACE programs. As it stands today, Georgia does not have any PACE programs, but in the FY 2024 Appropriations Act and House Bill 19, there's language that states, and Brian will go into more detail about this in a little bit, but that language in the budget stated the Department of Community Health shall conduct a needs assessment on the establishment of one or more programs of all-inclusive care for the elderly, so PACE for short is the acronym. I would like to first, before we get into the needs assessment, and Brian will go into that about the work the department's done over the last several months to complete that needs assessment, wanted to provide an overview of PACE for the committee members. I know, Chairman, you're familiar with this program, but I just kind of want to give some background on PACE, what it is, different components of the program, and what we're seeing nationally on it. PACE is a federal and state program that provides a comprehensive, integrated, and highly coordinated community-based care model and services to frail older adults who meet state eligibility criteria for the nursing home level of care. Individuals enrolled in PACE receive all services covered by Medicare and Medicaid, as well as additional benefits directly from the PACE organization or through its network of contracted providers. PACE participants receive services at the PACE Center and at their homes. The model is unique in that it uses an interdisciplinary team to assess and meet the participants' care needs. If there are services that are necessary for the participant that the PACE organization or that the PACE organization itself does not provide, the PACE organization must arrange for those services through contracted providers and still provide those services to the individual. PACE organizations receive per member per month capitated payments from Medicare, Medicaid, and private pay sources for which they assume full financial risk for all services, including long-term institutional care. So it's really a partnership between Medicaid, Medicare, and the PACE organization to provide payment and delivery of these services. And payments do not change, these capitated payments do not change based on the utilization patterns of the patients. It's important to note that beneficiaries who enroll in PACE agree to forego their usual sources of care and receive all their services through the PACE program. So that it's really that interdisciplinary team, those providers that the PACE organization contracts with, that provide that full scope and range of services, that comprehensive coordinated care, and allows these individuals to be served in the community versus in a institutional setting. Like I said, PACE is a Medicare program, and it's also a Medicaid state plan option. So it is an option for states to pursue this authority in their state plan. Like I said, Georgia does not have any PACE programs now, so it is not currently in our state plan. Nationally, there are 153 PACE organizations operating in 32 states and Washington, D.C. There's more than 300 PACE centers serving over 70,000 PACE participants across the country. Most PACE participants are dually eligible for Medicare and Medicaid services, and it's approximately 90% of the PACE enrollees nationally that are full benefit dually eligible beneficiaries. So I'll go on to the next slide now. Who is PACE eligible? So individuals who are PACE eligible they must reside in a PACE organization service area. So the service areas are limited to a geographic area. Some states have many PACE organizations and PACE programs, and some states have far fewer. For example, Tennessee currently has one PACE program operating in the Chattanooga area, while Pennsylvania has 19 PACE organizations in 50 different PACE centers. So it's really a geographical territory where they provide these services. Typically, Brian will get into this, but participants, per location serve about 100 to 250 PACE participants. They must meet the nursing home level of care. They must be able to live safely in the community, because again, they are served in that community setting while also being served at the PACE Center several times a week. Must be at least 55 years of age, and 96% of PACE participants live in the community. So the average age is about 76 years of age, and the average number of chronic conditions per PACE recipients is 6 chronic conditions. Next slide, please. So who can be a PACE organization? Nonprofit, private, or public entities are primarily engaged in providing PACE healthcare services, and the following list shows what organizations must have in order to operate as a PACE organization. A governing board that includes community representation, the physical site to actually provide the adult day services that most members or participants will receive several times a week. A defined service area, like I just discussed, the ability to provide the complete service package, regardless of frequency or duration of services, which they do through that interdisciplinary team and contracted providers, safeguards against conflict of interest, and demonstrated fiscal soundness. Next slide, please. So who is on the PACE interdisciplinary team? So the team consists of professional and paraprofessional staff that assesses an enrollee's needs, develops care plans, and delivers all services. And these include acute care services and, when necessary, nursing facility services. These teams include 11 members, and the next slide will show the different members of this team. So you can see it's a fully comprehensive model with dietitian. Transportation is a huge component of the PACE program. They provide the PACE organization provides transportation to the main PACE center for adult day services, as well as to any contracted providers that those individuals need to see. And then you can see the others: home care liaison, nurse, occupational therapist, the center supervisor, dietitian, and then that personal care attendants, physical therapist, primary care physician, recreational therapist, and social worker. Next slide, please. So what services are covered under PACE? It's important to note PACE is a Medicare Part D provider and provides full prescription drug coverage, including all Medicare, Medicaid, and medically necessary services with no benefit limitations, copays, or deductibles. And on this slide, you can see all the services that are covered. I'll note, several of them, like I mentioned. It's important that these individuals have the ability to, stay and live in the community productively. So the occupational therapy and physical therapy are big components there. The transportation is unique to this program as well, and that varies, per member, but several times a week. A lot of these individuals will go to and from the PACE Center, as well as meals. There are meals provided in this program. So that is another unique aspect, but you can see the full list there. Next slide. Okay, so what services are covered under PACE? Including but not limited to all Medicare and Medicaid services are part of this package. PACE also includes all other services determined necessary by the health professionals team to improve and maintain an individual's health. So because the provider is being paid on that capitated basis with the set amount, they are charged with ensuring that individual's healthcare needs are met. And just want to reemphasize again that the provider is at risk for all service costs including hospitalizations, long-term skilled nursing. Therefore, the provider is very incentivized to regularly conduct case management and care coordination, chronic disease prevention and management as well. And the model is set to do this through regular physical assessments of the members that occur at the PACE Center, as well as providing services at home and in the community. So with that, I'll turn it over to Brian, who will discuss more about the specific needs assessment that we conducted.
Thanks, Grant. So if you'll go to the next slide, Brandy, we did, as Grant said, as part of House Bill 19, we were requested to do a feasibility study of the PACE program in the last legislative session. So as part of that, what we did is we met with the National PACE Association, which we figured was a great place to start, right? The National PACE Association. We also contacted and met with individual providers of PACE that we were aware of, and we met with representatives from both North and South Carolina. We had previously spoken with other representatives. It's funny, when this first started coming out, we were moving from 2 Peachtree to the Twin Towers, and so we were, having to box all of our stuff up for the last 20 years. And I found like the old PACE presentation, the first one I had, that was from like 2007. And I was like, oh yeah, I remember this, it's PACE again. So we definitely looked at like Alabama. They have a center down in Mobile that is a very active PACE center. We also reviewed estimations of the potential number of individuals that might be served if we were to adopt PACE as part of a state plan option. What we learned from our assessment from providers was they were most interested in what you would assume they would be interested in, which is Metro Atlanta, Bibb County or Macon, and Chatham down in the Savannah region. Typically, a PACE program revolves around adult day health, right? So that's like you have to have the adult day health center that Grant discussed in the list of topics. And they tend to have around a 10,000 square foot facility, and they serve basically a 50-mile radius. It might be larger, but if you're that PACE organization, you have to start thinking about, we're covering all their services and transportation, so that radius becomes a consideration for them. And as Grant said, typically they serve 100 to 250 members that visit multiple times per week for services. So we asked the National PACE Association to help us with looking at Fulton and DeKalb, Chatham and Bibb. And then we were in discussions with another PACE provider who graciously gave us their assessment information and said, here's what we looked at when we were assessing Georgia. And through both of them, we kind of came to the determination that in order for a PACE facility, a PACE organization to be viable, they would have to have around 100 members that they serve at any given time. So we looked at, what we did then is looked at the number of nursing home members, because if you remember from it's been a presentation, but they have to meet the nursing home level of care, right? So this isn't open to any member that is 55 or over. They still have to meet that nursing home level of care, which is the same level of care we use for the elderly and disabled waiver. You have to meet a nursing home level of care for that. So we looked at who we would typically need to look at for entrance in order populations. Would there be enough folks to go into a PACE program? And we typically see that about 10 to 15% of those eligible enroll in a PACE program. The highest viability for those programs, when we looked at all the different areas, both from the provider and from the National PACE Association, was Fulton and DeKalb, but Bibb and Chatham seems to have more than enough members in order to make a PACE center viable. We also looked at, thanks to that national provider, we're able to look at Richmond, Gwinnett, Muskogee, and Cobb, who all we felt would be able to meet that criteria of keeping open and having 100 existing members. So right now what we're doing is we're examining the need for legislation in order to authorize the PACE program in Georgia. And also we're looking at what would be our ongoing performance measures and quality outcomes in order to stand up and incorporate PACE as part of our state plan. So typically when things like this come up, we get asked, because I'm the policy person for Medicaid, I get asked like, okay, so Brian, do this, right? Like there'll be a bill that's passed or it'll be in the budget. And I'll be like, Brian, do this. And then I'll be like, okay, well, there's steps. Like, because Medicaid is 2/3 funded by the federal government, right? So they tend to have some opinions on whatever we do as a state and ask a few questions. So what the steps would be for implementing PACE is development of the PACE policy. We have to develop a per diem rate, because the PACE programs are typically paid on a per diem basis. We would have to submit a state plan amendment. So we have, just like every private insurance, you probably get a booklet every year that talks about what your benefits are. Medicaid is an insurance program. So we have a state plan that says these are the things we provide out of our state plan. So we would have to incorporate PACE into our state plan. You have to contract with each individual provider and CMS. So it's like a three-way contract. So you have to establish a contract with the provider and CMS in order to stand up that facility. We'd have to have an aid category specifically to target the PACE participants, like we have an aid category now for NOW and COMP, or for the elderly and disabled waiver, or independent care waiver. And then we would have to configure GAMIS, which is the Georgia Medicaid Management Information System. It's how we pay providers in order to pay out these members on a regular basis. So that's kind of the quick version of what we would have to do to stand up a PACE program. That's it. So I was here for questions.
Okay. Thank you, and Deputy Commissioner Thomas, thank you for being here as well. This means a lot, that this is important to the department, and it shows that y'all are really engaged in this. So to be clear, just to make sure, we're talking about a capitated rate on this plan, which, so I might just get you to emphasize for the members that is really stands out markedly different than most of our waivered services. And also, so this really isn't a waivered service, even though it's serving that same population, or is it? Because you talk about state plan, so we have the waivers for E&D and NOW COMP and all the developmental. So help us to understand how it fits into the waivers and then how it pays different. Just emphasize that from our traditional waivers, I'll use that term.
Absolutely, and thank you for saying that. I try not to get too nerdy, so if I get a little nerdy, forgive me for a second. So what I talked about was the state plan portion like we have, but in addition to the state plan, you have waivers, right? The waivers are just that. It's what extras are you providing for what populations outside of what's in your state plan. and this may sound very antiquated and not make any sense, so forgive me, but it is the federal regulation. If you run a Medicaid program, you have to pay for nursing homes. You don't have a choice. You must pay for nursing homes. You do not have to pay for home and community-based waivers. They are not a requirement, right? I know that doesn't make sense. Everybody's probably thinking, wait a minute, he's not telling the truth. I actually am. So the waivers are extras to the state plan. So every single waiver, the home and community-based waivers, they only exist for 5 years. And then we have to reapply for them and then get them reapproved. We just went through that last year. They've all been reapproved for another 5 years. So those are extra authorities, and you can provide those book of services in addition to your state plan for those targeted populations. This would not be a waiver. It would be in the state plan. We would say, hey, we're going to start covering PACE organizations under these parameters, and we're going to pay a per diem, which is, you know, a per member per month for all the services they receive. Like Grant talked about, they basically are on the hook for everything if you enroll to be a PACE member. If you say, I want to be served by this PACE person, this PACE organization, then that PACE organization is going to cover you for everything. And not only does Medicaid provide a per diem, Medicare will also provide a per diem if they are duly enrolled.
That was very helpful, Mr. Dowd, and by the way, we're accustomed to the federal government not making sense, so that's nothing new. None of us are surprised by that. Let me ask you one question. So again, we're talking about a rate where, you're talking about a provider being at risk, which is, I just want to emphasize that is unique in the realm that we're in. And so, and that is indeed innovative. So to that point, so the different providers that you listed there, could any of those providers be a PACE site? So you've got to have all of those services. But let's say you have a day program that's, we have so many across the state that have such great, could a day service provider, an ADH, could they be a PACE site? And of course, they have to have contracts with all those other providers. Is there any requirement of what type of organization can be a PACE provider?
No, it's private, public.
So it doesn't matter the service, just
Yeah, as long as you can
the
cover all
entity.
the stuff.
Right, got you.
That's
Okay.
going to be
Just
that's
wanted to
going to be the thing. I mean, we do have we have adult day health providers that are very sophisticated, and they have other lines of business.
Yes.
And then we have adult day health providers that are just adult day health providers out there in the world. So, you know, but you could always like build up to be able to become a PACE organization.
Got you.
Or contract with other providers that need it for certain services that they don't have in-house.
Excellent. Okay, very well. All right, let's see. Representative Cameron.
Thank you. I live exactly on the border of Chattanooga, so I'm familiar with this program. With I think it was at one time it was the Alexian Brothers, but it exhibits some of the same characteristics, not all, of like a DSNP program. We have dual eligibles. I come from Blue Cross side. That's why I'm like you, I'm like a lot geek. But have we ever thought about that kind of program? Because we have probably 250,000 or more dual eligibles in Georgia, at least.
Have we ever thought about?
Yeah, doing not only a PACE program, but a dual eligible program, like a DSNP.
Well, we have.
Do we do it?
Yeah, we have contracts with several DSNPs.
Okay.
Through the state now. Yeah.
Okay.
I mean, I used to be over those. I'm sure they're still there.
Representative Hawkins.
Yeah, I'm trying to follow the funding on this. This would not be through a LIM type or ABD, but a different payment silo. Is that how this operates?
It would be part of it would be included in our age blind and disabled section of our budget.
Okay.
Because you would have, avoiding being nerdy. So you do have to meet nursing home level of care, and you have to be 55. So in order to be an age blind and disabled, you either have to be 65, blind, or disabled, and that's disabled is determined by Social Security.
Right.
Their standard is a little different than most. The Social Security standard is actually unable to work for at least a year. That's where they start. A lot of people think it's based on diagnosis, but it's actually not. It's based on functionality. So there could be some people between 55 and 65. we would assume that most of those folks would already be on disability, right? Because the vast majority of people who go on PACE
Right.
have Medicare. So we'd assume they've probably already gone through the Social Security determination process and been determined disabled, and they would also be included in our age blind and disabled category.
Right. So your providers, though, I heard you say this was a capitated plan,
Yes, sir.
so it's not a fee-for-service plan.
Well, you would get paid a capitated rate for each member per month.
So it's considered a fee-for-service just based on a capitated rate.
That's a really good question. Yeah.
Yeah.
What we would consider
Yeah.
it?
Trying
Yeah.
to see through how this is working.
Yeah, you see my face going, oh, that's
Yeah,
a good question.
yeah.
Because you're at risk, right? So we
Right.
would pay you that, and now you're going to have to provide whatever it is. It's also important to note that for PACE, the choice is the members, right?
Right.
So I can opt in or opt out when I want. If I'm not getting what I want out of the PACE program, I can say, no, thank you. I'm going to go out. And assuming I'm an SSI member out there, I get supplemental security income and I have Medicaid, then I would just drop back into, fee-for-service payment.
So you're talking about the provider, right?
I'm talking about with the member, yeah. I would
You
just,
talking about the member, or not the provider? How about the provider? Can they go in and out too?
no, if the member chooses and they get enrolled in the provider, then they're responsible for that person's care.
Okay, I'm just trying to follow how the provider would go through this system then. I mean, what's available for the provider as far as opt-in, opt-out? Are they flexible, opt-in, opt-out, or are they contracted in some way or obligated in some way?
I'm not sure what the obligation is. We would have
Right.
to check on that. I
It-
know that typically they have a max number of members that they serve because they hit like a threshold where they can't serve more, but usually they're wanting to enroll those members.
So you don't have any problem with the provider, the number of providers? I mean, you're okay and you're set with provider numbers?
Well, we haven't really started at this
Right.
point. So yeah, that would be part of our planning to ensure that our provider feasibility, make sure the provider has all the services
Right.
that are in place.
Right, right.
And make sure that they're able to serve the members who want to enroll in
Right.
whatever catchment area they decide to
Right.
start up from.
Right. I just see possibly problems down the road for providers with, because healthcare expenses have, gone through the roof for everybody. And most of the expense is actually the staff. I mean, that's where there's a lot of problem right now. Finding them and then affording them, especially nursing skill. So
Yes.
appreciate what you're doing, though. Thank you. Okay.
Thank you. Representative Cannon.
Thank you, Mr. Chair. Just one for each of you. I think I'll just stick to PACE to start, and then maybe I can ask you about the other piece. But these are set up as not-for-profits around the country or non-profits?
They could be either.
Mixture.
Okay, and so is there as we're looking at this conversation, has there been a leaning towards one or the other just because of tax exemption,
No.
There have been providers that have reached out and expressed interest, if the state does move forward with this. But like Brian said, it's really a mix, and any of those, within those categories of nonprofit, private, public can qualify.
Okay, because on our document here, it says 90% of PACE programs are not for profit. So that's why I'm asking more directly if you're saying that it's a mix.
Well, I think predominantly that information, I don't think we provided that, but nationally, it's, that must be the statistic for, that 90% of these nationwide are nonprofit, but that other 10% would include those others, for profit or public.
Okay, the reason for my questioning is just around like religious organizations having these types of PACEs. Is that typical or no?
I can't think of one off the top of my head that I've encountered. But I don't know. I haven't done like a deep dive into that question.
Okay, thank you. And then just my other question on it, the other subject that you started about the providers doing their re-enrollment, I don't know what it's called.
Yes.
But what we're hearing is that the reimbursement rates aren't high enough. And so some of the providers aren't wanting to, or are actually kind of letting the situation pass over them and say, oh, we missed it. So I'm just really curious how the department is responding to that type of feedback.
Well, we have done extensive outreach to the providers like I talked about. We also extended the revalidation deadline from September 15th to October 31st. We continue to do a lot of outreach through our associations and community partners. On the reimbursement rate issue, you know, there have been specific rate increases the last several years for different Medicaid provider types. And, you know, we have those, and that's just an ongoing conversation that occurs through the, you know, budget and appropriations process that you all are involved in as well, you know, when the budget goes through the legislature. So we're happy to always provide information and different facts, figures, and data, but, you know, we are a regulatory agency, and we implement the budget that, you know, is passed by the Governor and General Assembly, so.
Thank you. Representative Campbell.
Yes, thank you, Chairman. Thank you for this information. The first question I have is a follow-on from Representative Cannon's question, and I'm curious to know if you could share today, just give us a sense of pace, the total number of providers or the percentage of providers that have not revalidated at this time today.
So we are actively tracking that. I don't have that information available with me, but you know, we're happy to go back and then you know, provide it as a follow-up.
Do you have a general sense?
You know, a lot have complied, and there's still you know, many that haven't. So I don't have the specific numbers with me today, but
50%,
we're still
higher, lower?
I don't have that information with me today.
Okay. Seems like it's a huge part of delivering our care, so I know we're all eager to get that information. So would love if you could share that after this meeting. Then relating back to PACE, I want to make sure I'm understanding correctly. If the population has to meet the nursing home criteria, do all of these patients who participate live at home?
Yes, the vast majority of that. I mean, I don't know if it's all, but the vast
About
majority
90%.
of them, yeah.
Okay. And then my second question, just trying to understand the management of the care service provided. Would it be accurate to think about the way this process would be managed similar to maybe HMO services, where there is a singular point person responsible for care? The patients are going to multiple care providers. Services may be approved or rejected, just as in an HMO. Does that same sort of process apply here? And what would that look like?
So I would say yes. So I have Kaiser as a state employee, right? And I sometimes joke it's the Walmart of healthcare, right? Because you walk into one building and you get what you need. And if you don't get it in that one building, they refer you to somebody else that's in the network, right? Which I know some people really don't like and some people do like, right? So I think of this as the same way. You have a physical location for the PACE provider. It revolves around an adult day health, but that whole giant list of services that are there would either be provided on site or contracted through the PACE provider as part of their network. So yes, that's a fair representation.
Follow on to that. In a shopping scenario, I, as the patient, choose what I want to purchase. In this scenario, who makes that choice about what services are provided?
So as the member still has the right to choose to be in PACE or at any time choose to be out of PACE, and then they would be a fee-for-service member right now under SSI or whatever aid category. So their choice is much like myself with Kaiser, right? I can't go see anybody I want to, right? I'm gonna have to pay out of pocket for it, right?
But also, Kaiser, in that scenario, sorry to interrupt, I just want to clarify. But Kaiser, in that scenario, makes the determination that you can get the care or not who provides it necessarily. And so some care could be denied in this PACE scenario. Is that correct?
Well, I mean, with anything we do in Medicaid, we determine
understand.
eligibility based on medical necessity.
Understood.
So if they're responsible responsible for those services and it's medically necessary, the explanation from the state and our oversight would be that they receive it.
Thank you.
Thank you, and I'm going to ask our members to ask quick questions and also quick responses. We're going to have to keep moving on our agenda. I do want to say one thing. I want to thank the department for pushing the date back. I know you had to fight with CMS to get that done on the re-enrollment of providers, and I want to also emphasize again, as someone who's been a provider, that is a provider's duty. It's not. We shouldn't have to drag people to do their job. So the provider who gets paid for serving individuals needs to ensure that they're going to get paid by doing this very simple process. I have made sure that I told all the associations about this because we need to spread the gospel. But again, providers have also got to do their job. That's kind of fundamental to this. Who is next? Representative Okoye.
Thank you, guys. This has been very helpful. Mine is a question and also a suggestion. Now, do you sign contracts with the PACE providers?
Yes,
You do?
we would have to have a contract.
Okay, that answers the question, because if not, we're going to put should I say patients or members at risk. But as long as you would have contracts with them, that's good. Thank you.
Representative Hood.
We've talked about the capitated cost, but I don't know that we've heard what that cost is. Is it a flat rate per person that enrolls? And what is that?
It would be set by our actuary who does the actuarial analysis on the other capitation rates that we pay. So it would just depend on their assessment of the population, the health, their assessment of the costs, and then that's has to be certified by CMS.
Okay, so it's really undetermined what this would cost the state and how efficient it would be.
Right. Until we get further along in the implementation process.
Right.
Yeah, and they do that assessment.
But if I understand this correctly, kind of like Chairman Hawkins was saying, that the PACE provider, they would lean towards providing services to the PACE recipient in the most cost-efficient manner as possible, so they can make out and keep that risk, mitigated.
Right.
Okay.
Yeah.
So
And I think to your point, they have that incentive because they're being paid that flat capitation rate. They want to make sure they're managing, chronic disease management, case management, that they're addressing problems early on so that they don't become more acute and have to pay for a nursing home, institutional, or hospital stay or a.
So I like the idea of, trying to be efficient, as a state. So I would certainly appreciate more conversation on this before decisions are made. And I know that's what you're doing, research and looking into it. In this discussion today, I think more of our presenters on the agenda are going to talk about some ideas on how to, provide services to aging individuals in a cost-efficient manner that supports dignity and, gives the care that's needed. So, thanks.
Deputy Commissioner, thank y'all. I think that is all the questions. Thank you for being here. Very interesting. And we're going to have our next speaker, Ms. Benton and Mr. Espina from Savannah Hospice down my way, are going to talk about a PACE pilot project, as I understand.
Good morning. I have to thank Brian and Grant. They teed me up very well, and I have collected all of your questions that I hope I'll be able to actually answer through what we've spoken about so far with PACE. I also want to thank this committee in general because having worked in the seriously ill population and end of life my entire career, what you've done to establish these guidelines and the baselines for what we're experiencing in Georgia is, I just have a lot of gratitude. It's refreshing to sit in front of a committee that sees what's happening with the aging population and that knows that we really are in a perfect storm, because beyond the aging population, we also have a labor shortage at the same time. Personally, I do want you to know, and I have to thank Chairman Petrie especially, that my youngest brother was born with the same disease as the Elephant Man and was a patient of SOURCE. And that's important to mention because you were a part of making that happen in the state, and I've walked through the life of a SOURCE family. It's what makes me passionate about this work. I'm Kathleen Benton. I'm the CEO of Hospice Savannah. I'm the CEO of 3 nonprofits. We have a nonprofit that focuses specifically on caregivers, which is going to come into discussion today in the labor shortage. We have a nonprofit that certainly does hospice care, and we have several hundred members under that program. And then we also have a robust program that just concentrates on seriously ill, non-dying patients in an outpatient clinic setting. So we serve thousands of patients and thousands of caregivers in our area, our counties surrounding Savannah. So I really represent both personally and professionally the type of population that we're talking about today. I have for the last 2 years been researching PACE. And so instead of starting with my own presentation, I want to go ahead and answer a few of the questions that were asked earlier today. Not-for-profit was brought up. 90% of these are lifted up by nonprofits. Much of the time it is by hospice organizations. And you may, why hospice? These are not end-of-life patients. These patients are, they have many years left of life. Well, because a big part of what makes hospice different from other healthcare is that when you need someone urgently at 4 a.m, there are very few providers that don't tell you to call 911. Hospice does not tell you to call 911. We go to our patients right away at 4 a.m., Sunday morning, Saturday morning. And when a hospice lifts up a PACE organization, they do the same for their patients. So they don't necessarily keep them at home. If they need to go to the hospital, they can go to the hospital, but the PACE provider goes with them to make sure that it's not a disjointed care effort. And I really think the best way to explain PACE to this committee and everyone listening is to tell a story. I think I hope that will be most helpful. So I want to introduce you to a patient named Mary. Mary is in her early 70s and has early onset Alzheimer's disease. She also has hypertension, she has diabetes, she has congestive heart failure, and she has COPD. And Mary could be a PACE patient. Mary is being cared for by her husband, who also has multiple comorbidities, and it is a struggle to care for her every day in the home, but he is diligent and he is committed to not putting her in a nursing home. We oftentimes see caregivers who then become the patient prior to the patient going downhill because of this type of care that Mary is being given. Mary also has many orthopedic problems, and at home she experienced a fall where she fractured a hip and had to go into the hospital. Because she had congestive heart failure, because she had COPD, Mary stayed for 81 days in the hospital. Why did that happen to Mary for a hip fracture? Partially because of the disjointed care that we have today. And how would that be different in a PACE program? In a PACE program, Mary would have options. Mary would have a network, just like we all have right now with our own commercial insurance programs. She would be able to choose who is her orthopedist, who is her neurologist, who is her cardiologist, who is her pulmonologist. But the difference would be that her husband would not have to take her to all of these appointments. That is very different from how a waiver program functions right now. When Mary goes to the day center, she would go for therapy. She would go for speech. She would go for PT. She would go to make sure that all of her care was reviewed by an interdisciplinary team. This is something that a hospice does right now for all of our patients as well. We always use interdisciplinary review. These patients are reviewed almost every single day. In answer to, I believe, a question from you, Representative Campbell, about what is the attrition rate for PACE providers? It is extremely low. it is not in the 50% range. It might be closer to 10%. There's been, in fact, one recent scandal with the PACE provider where they were cherry picking more well patients. That was a bigger issue. It was a large for-profit company. For-profits still do PACE well. That is not to say that they don't, but 90% are run by nonprofits that actually produce a smaller margin. They, of course, are committed to the community and the board, not stakeholders. So it is acceptable for them to have a smaller margin. And PACE attrition for patients is also very low. And that is because they have a team that carries them along. So if Mary had fractured her hip under PACE, the PACE nurse would have showed up to her home and gone to the ED with her. They would have regular review meetings with the interdisciplinary team at the hospital, and they would be talking to her neurologist, her pulmonologist, her cardiologist, her orthopedic surgeon. Mary would not have had an 81-day hospital stay. It would not have all been on her husband. We have done an excellent job in Georgia, committing to caregivers. There's really no answer for our labor shortage. I think that was represented very well earlier with Deke. We're going to have to look for inherent caregivers, and those are in the homes. Those are excellent caregivers for us to rely on. We just have to support them. We have to provide them respite. That is another large part of the PACE program. Not only are they able to go to the day center for all their therapies and transported to all their doctor's appointments, so it actually doesn't act like a day care center. Instead, it acts like multiple doctor's appointments, which is actually much easier for families to commit to and patients to be okay with. You know, not everyone feels like it is okay to go to a daycare center. It works for some, not for all. That's why this is a great choice for some, not for all. I believe DCH has done an excellent job with this feasibility study in showing that our state, just like all our neighboring states, support this very well. South Carolina, North Carolina, Alabama, Tennessee, Florida, all of them. 32 states right now. Within the next 12 months, it'll be closer to over 40 states that have these PACE programs. Again, because attrition is low, both for patients and providers. These programs are committed to a very joined effort for patients, and thus the patients do well. It's not efficiencies in the way of excusing needed resources. It's efficiencies in the way of looking at care that becomes redundant when one specialist does not talk to another specialist. And for example, may double order MRIs. Thousands of unnecessary ED visits because symptoms aren't managed when you're treating the kidney and the heart, but you're not treating shortness of breath on a regular basis. Most of these ED visits for these type patients are because of symptom management issues. Most of the time, PACE providers have palliative care physicians who go to school for pain and symptom management. Their organ is pain and symptom management and the art of conversation. That's what a palliative physician does. It is what their fellowship is in. They're very good at talking through all of these different options with the caregivers, the patient, and the entire team. That's how the efficiencies are found. It's not found in shortage of resources. PACE programs throughout the United States do very, very well, and I believe that Georgia would succeed. What Hospice Savannah would like to do is to lift up a pilot program, very simply, that would start in Q4 of 24-25. It takes over 12 months to set up a PACE program. It takes a substantial amount of time to build a network that allows for freedom of choice, the kind of freedom of choice we believe all of these patients deserve. So knowing that that has to happen, a pilot program would allow us to push this forward in Georgia in a shorter period of time, and DCH to get some real information out of our own state on whether this works here, not if it works in other states. I have provided you a bullet-pointed informational sheet on lots of different questions answered for PACE. I am attempting to work with DCH as well on many of these bullets. Hospice Savannah has already employed a consultant that has lifted up 60 PACE programs across the United States. So we're well informed in how to do this the right way. We can really help people like Mary make this program work. And it's not just for Mary, it's for her husband, so he doesn't quickly become a PACE patient himself. Efficiently, we can help his disease progression by taking care of him while he takes care of her. So with that, I'm not going to read through all of these different bullets. I'm going to keep it sweet and short and ask if you have any other follow-up questions that you already asked DCH. I really want to join the state in trying to make this work for Georgia. Did I just say everything right? Yes. Okay.
Representative Lupton.
You said everything great.
Okay.
You were speaking specifically of Hospice Savannah having these
ma'am.
3 different kind of arms, and one of them being, caring for providers as well, for the caretakers. That is specific to you, not necessarily specific of all PACE programs. Is that correct? Okay. That's
Although I will say that, again, you can look in the literature, and I'm sure DCH will find this as well. It is programs like mine that have lifted up over half of these across the United States. And it's for the reasons I said. We're used to treating patients at 4 a.m. We don't send them to the ED. We have those type resources. We know what interdisciplinary review is.
Mm-hmm.
It's good for dying patients. It's also good for patients who aren't dying. It works the same way.
great. Thank you so much.
You're welcome.
Representative Cannon.
Thank you, Mr. Chair. So real quick, do you know the answer with the conversation about 90% are not-for-profit
Yes,
versus nonprofit versus religious organizations? If you can speak to
Yes,
that.
ma'am. You had left, but I wanted to address that with you. So yes, 90% are nonprofit, and a lot of that, and no, not religious. The only religious organizations I know to be involved in PACE are, and in fact, I believe there's only 1 or 2 in the Catholic healthcare systems, if you consider that. And that's healthcare, not necessarily a religious organization. There's not a real reason other than the programs don't need to make as much of a margin. So as for-profits, because of course we're indebted to the community, not stakeholders. So it's just a different model of care. So we're able to put those resources into our patients. And I think earlier a question was asked about an amount of money. So based on what my consultant did looking at neighboring states, we'd probably come in at about $4,700 a month. Now, I don't have Brian's expertise, and his algorithm will be, the true science. But based on what our neighboring states do, it'll be right there. And of course, that's much different rate than about $6,100 spent on nursing homes right now, and includes full care because it's a dual service.
Oh, I'm sorry. You still question?
I do have one more question.
So
I'm
90% are
seeking-
nonprofits, not religious organizations.
I hear you. I'm just seeking clarity because the document says 90% are not for profit. So I'm asking the difference between nonprofit and not for profit for the purpose of understanding tax exemption status for
I apologize.
PACEs.
That's just the language, the exact same thing. So not for profit meaning nonprofit. I can clarify that. Same thing. I'm not differentiating. Not for profit is nonprofit. Both 501c3.
All right.
This is citing nonprofit 501c3.
Okay. Chairman LaHood.
Hey, thanks for addressing the rate question from earlier. Just for some perspective, can you tell us, as a history of a hospice provider, what is the reimbursement rate for hospice?
It differs. It's a per diem, and that's another. We act like a risk-based program right now, so we budget for all of our patients. So again, very similar. We get about $180 a day for the first 30 to 60 days of care, and then the rate decreases as we go along, the 6-month benefit.
Okay, thank you.
Now, there are 2 other levels of care, just so you're aware. We do respite care in a facility, and that's at $489. And we also do an in-hospital hospice stay. Very few of us have in-hospital hospice because it's a huge loss in money. I have one because we're dedicated to our community to keep it there. that rate is about $900 a day. But the patients only stay for a few days until we get pain and symptoms under control. So most of it is that routine care at about $180 a day.
Okay, so the $4,700 a month for PACE
Yes, sir.
would be slightly lower than the hospice rate.
But
sounds like.
right, but it's joined by Medicare. So the state puts in $4,700, it'll be matched by Medicare, and that's what I'll have to work with to pay for these patients, which is important because, of course, hospice patients don't receive aggressive care. These patients will absolutely be receiving very aggressive care, hip replacements or chemotherapy or anything they need.
Okay. So was there ever a scenario where the patient would be on hospice and PACE at the same time?
Not usually the true benefit. So what the PACE provider might do is have the patient on less aggressive care measures through a contracted hospice organization, but they won't usually turn the benefit to a true Medicare Part A hospice. No. Most of these patients do not end up on hospice. They continue on PACE.
Okay, thank you.
No further questions. Mr. Spina, anything for you to add? All right. Thank you all for being here, and we appreciate you. For all the members, here's what we're going to do. We're going to take a 10-minute break at 12, which is in a few minutes. We're going to have Miss Terry Barcroft, my friend, who I haven't seen in a long time till this morning, is do a quick presentation, and then we're going to have we have lunch that was kindly brought to the members here. We're going to just, if y'all are okay with it, have lunch while we continue. So to respect everybody's times here, we're trying to get everything in within the time that we allotted, which was from 9:30 to 1:30. We do, and I think we're going to do that. All right, Ms. Barcroft, so glad you're well. Floor is yours.
Thank you. Thank you so much for allowing me to come and speak. So good to see you, Chairman Petrie. I'm Terry Barcroft. I'm with Wesley Woods Senior Living. Wesley Woods has been providing housing and services for older adults in the state of Georgia for the past 50 years. We serve 1,800 older adults every year through a variety of services, and we serve a variety of older adults through the economic spectrum. We serve folks from extremely low income in our Section 8 affordable housing up to our very affluent older adults within our life plan communities. We have over 700 affordable housing apartments in the state, 172 personal care and or assisted living beds, I don't like that term, apartment homes, and 56 covered beds under the skilled care nursing program through the life plan community. So we have a broad spectrum of those that we serve. I want to speak specifically to, and why I'm here today is for House Bill 582 in an effort to create more accessible options within the long-term care program. In our affordable housing communities in particular, Marys, as Kathleen mentioned, live in our communities. Unfortunately, they don't generally have a husband that is providing that additional care. So what we are doing in our affordable communities, Section 8 housing, is that we have service coordinators that are attempting to help these folks connect with services. And whether they do meet those criteria for a skilled need and comorbidities, I can name a handful of folks in each of our communities who really need assisted living care, but they don't qualify or they can't find a spot for that care in a home. Now, they, again, meet the level for skilled care. They don't need 24-hour skilled nursing, but what they do need is 24-hour watchful protective oversight. What Mary's husband provides her is what's needed. So in our community in Augusta, we have 267 apartments. 40% of those apartments are covered under a Section 8 contract. 60% is market rate. And we have a very small personal care program there that's licensed to provide care. We have 5 to 8 residents that I can speak of right now who need to move into our personal care program licensed under the state. Some of them do qualify for CCSP and have those services in the home, but it's not adequate to cover their need. They need more oversight, not necessarily more additional care. We have charitable care through our foundation. We provide over $1 million every year in charitable care across our organization to make sure people stay in their Wesley Woods homes and don't move to higher, more restrictive, more expensive levels of care. But that's not enough. And every dollar that we spend to try to help those residents move into our personal care programs to get those services that they need, there's someone else who's either having to leave Wesley Woods to move to a higher level of care simply because we don't have the funds to help them or the place for them. So it's an important element, it's an important opportunity for us to be creative and helping to serve older adults in a different environment. I'm not suggesting by any means that it becomes mandated for all assisted living or personal cares, but I think to be able to expand that opportunity for older adults to have access is really the critical point. I'll give you another example. We have land in Blairsville, and as was mentioned earlier, the need for additional care in the upper north Georgia is important. We would like to build an assisted living community. Right now, the way the regulatory language is written, we'd like to build a community that's 48 beds. I would like to have 24 of those covered under the Medicaid program because we have 138 apartment building covered under Section 8 there. Those residents need a place to move to a higher level of care but stay home. Right now, I have to have 2 separate companies, one that's 24 beds or less, and then the other 24 bed, push them together for economies of scale to make the pro forma work. But it's just a complicated barrier to something that should be so simple to be able to provide care. So I see it as a perfect mix of public money, private money, as well as philanthropy that blends together to serve older adults. We do that in Augusta, and you never know, like Mr. Cato talked about at AG Roads, you don't know who's on Medicare or who's on Medicaid. You don't know in our communities who's receiving Section 8 funding or private pay. I think it's a beautiful way to blend those economies across the spectrum. Thank you. Questions?
Thank you. Any questions from the committee? All right, hearing none. Tom Bauer.
Morning, Mr. Chairman, members of the committee. Thanks for the opportunity to be here. My name is Tom Bauer, and I'm representing Leading Age Georgia. For those of you who don't know, Leading Age is an association representing a diverse group of nonprofit and other mission-driven senior care providers with distinct constituent groups such as adult day services, home and community-based services, senior retirement housing, assisted living communities, continuing care retirement communities, now called life plan communities, nursing homes, and hospice care. Leading Age is also a member of COAGE, and we're pleased to address one of the legislative issues being promoted by COAGE that offers another option in terms of long-term care choices, and that is to allow residents of assisted living communities and large personal care homes access to Medicaid home and community-based services. Leading Age presented this COAGE issue to COAGE because some of our members, like Ms. Barcroft, are senior living residences, which people with lower income residents who live in subsidized housing. And I'm not actually going to read the rest of this paragraph because Terry Barcroft actually presented very well the issue that we have folks who can no longer live independently but don't have that choice of where to go. And the one thing she didn't mention is that they would be forced prematurely into nursing homes, and because they can't get the level of care because of Medicaid being prohibited. And I think Ms. Johnson mentioned that there are a deficit of nursing home beds anyway. So COAGE and Leading Age asked Chair Lady Cooper to introduce legislation to change these policies and expand access to Medicaid waivered services. In a nutshell, House Bill 582 is a conservative bill with 3 major provisions, and I think that bill is in your folder. First, it repeals the prohibition against assisted living communities enrolling in Medicaid and receiving Medicaid funds. Second, it would allow the same option for personal care homes of 24-plus beds if allowed by federal rules or law. Third, it directs DCH to involve stakeholders in developing a model for this purpose that is initially restricted to providing Medicaid waiver services to the modest number of 200 residents. This end could be met in many ways, including amending Georgia's 1915C elderly and disabled waiver, or applying to CMS for a new waiver with a specific cap. This would be determined by the department after discussion with stakeholders. I want to address a few arguments that have been raised in opposition to allow Medicaid in assisted living communities and large personal care homes. One is that the floodgate of persons seeking services will be forced wide open. However, it's important to remember that House Bill 582 or a similar approach would be completely permissive. No ALC or large personal care home would be required to participate. However, some facilities might want the option to allow residents who've run out of money in this private care facility to remain in their home. In reality, it's doubtful that such facilities would respond in large numbers to accept Medicaid. This is because waiver services do not include room and board. Thus, since these are private pay facilities, they would have to make up the difference in a bed generating funds at the home and community-based services rate or the room and board rate. Thus, it'd be unlikely that the floodgates will be opened by allowing this to happen. The private care model simply will not sustain that many Medicaid beds at a home and community-based service rate. Another concern has been the potential costs. This is precisely why Chair Lady Cooper began modestly with a limit of 200 recipients. And if the cost of developing such a model is a concern, COAGE, I think, would be perfectly willing to advocate for funds in the budget process. It's just crucial that we increase our long-term care options for Georgia's seniors. Another argument that is raised is that facilities of more than 24 beds cannot be considered non-institutional. Leading Aid would submit that this number, which is part of DCH policy, is really arbitrary. It's conceivable that an 18-bed personal care home could be much more institutional in nature than a 40-bed facility. It really depends on architecture. You mentioned there are architects here today, Mr. Chairman, staffing, and the policy of the residents. Indeed, Mr. Cato described the household model being developed at AG Rhodes, and COAGE representatives have visited a licensed nursing home with 100, I don't think it's 120 beds yet, but they are considered a household model and they operate with Medicaid. It is Leading Age's belief that residential facilities should be reimbursed based on level of care, not the number of beds. It's also been contended that allowing Medicaid waivered services in large residential facilities would not be allowed under the CMS community settings rule, which I think y'all have heard about in the past. But I think you'll hear from Ms. Alter with Health Management Associates in their national scan of assisted living that many states have allowed Medicaid home and community-based services, and they managed to meet the community settings rule. I think that report also is going to note that various Olmstead agreements have been accommodated in states where there's a Medicaid and assisted living. Many states are enrolling assisted living as Medicaid providers. And finally, although some states were the focus of the HMA report, some of these states have minimum bed numbers as parameters for Medicaid reimbursement. None other than Georgia has a maximum, which is that 24 bed that Ms. Barcroft and Ms. Johnson mentioned. We appreciate your consideration of these points and would be happy to address anything.
Thank you, sir. All right, we have down there Representative Fry.
Thank you, Mr. Chair. Thank you, Tom. Do we know what was the original reason that these carve-outs were put in place? And that number was, how long ago was it? What was the point of all that?
That would be a DCH question.
Wish they'd have stayed.
Huh? Okay. They have intimated that it's part of the Olmstead agreement here in Georgia, but quite frankly, the Olmsted Agreement, all 72 pages of it, I have read, and it is dealing with the now waiver and the comp waiver and not the elderly and disabled waiver. And quite frankly, I never found a 24-bed mention in there anyway. It's been a DCH policy for a long time, probably predating that Olmsted as well.
Any other question? My understanding as well, Representative, is it was related to Olmsted and the drive to keep things non-institutional in character. That goes back. That's just, and I thought it was from the feds, early on from the feds to the department. But at any rate, I wish the department had remained so we could have got
Mr. Chairman,
more clarification on that.
We've done a lot of research over this over the years and talked to the feds, and it's not a federal policy.
It's not federal.
No,
Okay,
no, sir.
got you. Representative, yep.
Just a
Representative Fry.
follow-up statement. It does seem like that if it was attributed to that Olmsted Agreement, that it potentially got caught up in the error of omission,
Yeah.
since it wasn't listed, and so if you're putting it in there as far as having to follow the same policies as the other waivers, maybe we could change it administratively. Am I right?
I believe you can modify. I know Mr. Dowd addressed the 5 years that for the waivers, but I think you can petition to amend a waiver.
Yeah, the waivers are amended every 5 years.
But I don't think you necessarily have to wait, Mr. Chairman. I think.
No, I think you can amend them, and actually, I think you have Ms. Alter coming up. She has great experience in this background. She probably could speak to that as well. But you can certainly amend them. But most of the waiver, even like your IDD waivers now in comp, they all have caps too. So, for example, you can only serve individuals in 4-bed homes with those waivers. So again, it would be good to get further clarification. I'm sorry the department left.
And Mr. Fry, just to reiterate, I mentioned the now and comp waivers. Those are for people with disabilities.
All right, Representative Chairman LaHood.
All right, thank you, Mr. Bauer, for the presentation, and just want to clarify a point you made and something we've talked about offline for the benefit of the committee and the audience. But you mentioned that your proposed legislation would allow these Medicaid services in a larger personal care home or assisted living community,
Yes, sir.
essentially with 25 or more beds. But you're not proposing that those providers will be mandated to participate in the Medicaid program.
I may have read too fast. This is permissive. And one of the points I did not make is that one of the reasons, a couple of the reasons that they might want to, well, I did mention when somebody runs out of money, they might want to let them stay. But as well, because of vacancy rates, we think that some assisted living communities and large personal care homes would rather have something at the home and paying for that bed at a home and community service rate rather than it being vacant. And so the difference between the home and community service rate now and I think the average, at least assisted living community rate, is about $100 a bed a day. So you have to make up that difference. There are some ways, Ms. Barcroft talked about it, and I think Social Security for the person also does that. But just for all those reasons, we think it should be permissive and it would not be widely used.
Right, and I think it's also important to point out the skilled nursing rate that Mr. Deek, referred to earlier. I think Chairman Petrie looked it up. The average is 224 a day, somewhere in that neighborhood. 224.67. Yeah, 224.67. And if I'm right, somebody please fact check me, but I believe the current reimbursement for Medicaid in a personal care home is around $55 a day.
That's correct.
That's correct. Thank you, Chairman LaHood. All right, no further questions. I'm going to do one thing here. Ms. Alter, thank you. Thank you, Tom. Ms. Alter, if we can go to you next, we're going to jump around a little to continue with this discussion. I think we'll go to you next, if that's okay. I saw you back there.
I was expecting you to take a break.
Well, yeah, I think we're just going to keep rolling.
Okay.
I think our members would like to keep rolling. So we're going to do, now if you want us to go ahead and go to Ms. Petra, we can do that. Okay, gotcha. Okay, I'm sorry they ran out, so John, will you help me with that? Okay, I made a mistake. Sorry. I know you're going to be speaking to the same subject as I understand it that
That is correct.
Mr. Bauer was discussing, so I thought that might make more sense.
Okie dokie. Good morning, Chairman Petrie, and House and Human Relations Aging and Committee members. I'm Marcy Alter, Associate Principal with Health Management Associates. I am going to stick to a script because when I go extemporaneous, I tend to go way off on a tangent, and I know we're on, want to keep this as concise as possible. I want to thank you for allowing me the opportunity to speak today, to share information about the long-term services and supports landscape as it pertains to state coverage of services provided by assisted living facilities through a Medicaid benefit. Health Management Associates, or HMA, hopes to share new information with you that will be informative to your deliberations and processes. The information I'll be sharing with you today is a summary of takeaways from a white paper HMA authored for the Coalition of Advocates for Georgia's Elderly, or COAGE. HMA's team of LTSS, Long-Term Services and Supports, experts are committed to promoting the design, financing, and operations of effective models of person-centered long-term services and supports, and bringing forward trends and best practices to spur innovation. And while we're not advocating specifically for one approach or another, our goal is to help shape enhancements to LTSS delivery systems for increased access and improved outcomes for beneficiaries. Being familiar with the state's stance on Medicaid coverage for assisted living communities here in Georgia, when COAGE asked HMA to conduct research to learn where other states land on this issue, I was excited to learn more myself. A couple of notes before I move forward. Throughout this presentation, I will use the term assisted living facility, or ALF, as a catch-all universal term, but acknowledge that as we discuss, states do use different terminology to denote different levels of care, or simply use another term altogether for similar types of facilities. Also, we do include the District of Columbia in our references to states, even though it officially is not a state. I wanted to talk a little bit about, just set the stage in terms of the approach and the methodology we took to prepare for pulling this white paper together. We used existing research findings from the 2022 edition of the State Regulatory Review published by the American Healthcare Association National Center for Assisted Living. HMA identified 45 states that provide reimbursement for services delivered by or in an assisted living facility. We gathered and assessed the regulatory structure for assisted living facilities in each. Of the 45, we identified 17 states that provided Medicaid coverage for services available through a 1915C waiver. That's the authority for our home and community-based waivers. Of those 17, we further considered the state's regulatory definition of an assisted living facility to ensure comparability to Georgia. We additionally considered whether the state's service delivery system was exclusively managed through managed care or fee-for-service. We prioritized those that use a 1915C waiver authority targeted to individuals who are elderly and or disabled, and identified a subset of 11 states for further comparison. For these 11 states, we ultimately selected a subset of 6 states for focused review. We looked more closely at the specific regulation and policy governing Medicaid reimbursement under each state's waiver. We also considered each state's experience with implementation of their statewide transition plan for compliance with the Home and Community-Based Services Settings Rule. Wanting to ensure an apples-to-apples comparison, we also confirmed which states' assisted living facilities admit residents needing a higher level of care, and we narrowed the scan to states that allow their assisted living facilities to provide limited or periodic nursing services. We also, if possible, and wanting to drill down a little bit more, wanted to include states that share common characteristics with Georgia, such as size, demography, and political culture. We ended up selecting a final cohort of 6 states for conducting a deeper dive. Our approach was to follow up with each state directly to collect qualitative information from the state's policy, or about the state's policy, on and experience with Medicaid coverage in assisted living facilities. We wanted to understand what obstacles they may have run into by offering services in an ALF through Medicaid, whether there were any lessons learned, particularly as it related to compliance with the Americans with Disabilities Act, which requires states to provide services in the most integrated setting, and with regard to compliance with federal HCBS settings rule, which requires settings eligible for HCBS as reimbursed for Medicaid to not have characteristics of an institution. Jumping straight to our findings. 1, most states have relatively similar definitions of assisted living, although some states may title it differently. There's a common set of services that are typically provided in assisted living facilities, with personal care at the foundation and supplemented by nominal skilled nursing supports, as well as social and community integration activities. The great majority of states do not distinguish the type of facility by the number of residents or number of residential units. Medicaid funding is routinely used to reimburse services in licensed assisted living facilities of various sizes, from small to large across the country, including for HCBS recipients enrolled in 1915C waivers. This includes coverage of services in memory care units. Based on this review, there's no correlation that we have found yet between Medicaid reimbursement and the size, being the number of units or beds, of an assisted living facility. From this slide, I want to highlight that many states do not establish a minimum number of residents for licensure, and most do not set a maximum. If established, states typically tend to set a floor of 3 to 4 residents for an assisted living facility. This points to Georgia's uniqueness in how it differentiates the personal care home level of care from the assisted living level of care by the number of units or residents that can be served in the facility. Our research findings, including our regulatory review, the review of 1915C waivers for the subset of 11 states, and the responses we received from our outreach to the 6 focus states, resulted in several takeaways. First, funding diversity. Use of assisted living offers particular benefit in that it is an option that may be funded through diverse funding streams. There's also great alignment with HCBS goals. Use of assisted living facilities not only increases and supports greater choice of HCBS living options, but it can also increase community integration through community activities and extends the ability of the HCBS system to serve individuals in a community-based residential setting as their support needs increase. There are also inherent cost effectiveness and cost controls. The use of assisted living facilities is typically more cost effective than any institutional setting. It often can be more cost effective than providing services in an individual's own home. Moreover, the ability for assisted living facilities to enroll in and receive reimbursement from Medicaid does not inherently increase costs. Costs for 1915C waiver programs are controlled by the number of slots. Adding a setting where HCBS can be provided has no effect on the number of slots that are allocated and approved in the budget. Waiting lists. States that use ALFs have no waiting list or a relatively small one. In terms of HCBS regulatory compliance, there's no waiting list. There is ample evidence that assisted living facilities, regardless of size, can conform to the standards for for meeting the characteristics of a home and community-based services setting in compliance with a home and community-based services settings rule, even under conditions of heightened scrutiny by CMS. Also, the prevalence of states that have a long-standing history of covering personal care under Medicaid in an assisted living facility provides overwhelming evidence that such coverage is not a threat or a risk to meeting the spirit of the state's obligations under the Olmstead decision. We've talked already about the alignment with HCBS goals. It provides greater choice of options. It can increase community integration. It provides a stable living arrangement with appropriate monitoring and oversight akin to the needs or correlated to the needs of the individual. It can flex to individuals' level of care needs as those needs change, and it also can decrease isolation. And of course, it also can contribute to rebalancing the state's investments between institutional and HCBS services. Keeping in mind that this paper is not just for Georgia, although intended to address concerns in Georgia, we have several considerations that may or may not be applicable that Georgia would want to consider. First, impending demand. Nationally, the population of seniors 80 years of age and older is forecasted to grow over 9% between now and 2027. More affordable assisted living options will be essential to meet the needs of this growing population. Also, according to Senior Living, the average U.S. nursing home will need to add approximately 20 beds to keep up with population growth. Yet the baby boomers who are counted in this number will be more likely to want to age with dignity in place, and if not in their own home, then in a setting that is more home-like. Adequate funding for administering the program is of course important. States should consider what the cost might be to implement and support the program on an ongoing basis. Georgia already licenses and regulates assisted living facilities and personal care homes. The infrastructure for overseeing assisted living communities is already in place and should therefore not pose an administrative burden, but of course, the research is needed to determine that impact. Financing. Waiver services are designed to be more cost-effective approaches to long-term care as compared to institutional care. By federal requirements, home and community-based services must be budget neutral as compared to institutional care. The more access there is to community-based care and the longer the individual can remain safely in that community-based care setting, the greater the long-term care savings are to the state because it reduces a more costly and longer stay in an institution. Workforce. If ALFs are added to the Medicaid long-term care continuum and there are more stringent staffing ratio requirements, this could exacerbate staffing shortages in long-term care overall. On the other hand, assisted living facilities offer a more economical use of labor. It takes fewer direct care workers to support multiple individuals in close proximity than it does to provide one-on-one care and to travel than it does to provide care among multiple homes over the course of the day. States should work in partnership with providers to determine how the labor market might be impacted by adding assisted living to their long-term care continuum and the staffing requirements for assisted living facilities. Georgia's assisted living communities and large PCHs have already been required to meet stricter staffing ratios than the average nationally, and the addition of a few residents ought not to require significant staff additions. Our recommendation is that because ALFs are widely recognized as part of the HCBS continuum, states that do not provide such Medicaid coverage should consider how adding assisted living facility services to the LTSS continuum can improve access to care, increase care delivery options, and provide a cost-effective alternative to supporting individuals as they age and their support needs evolved. We understand that there are many ideas as well as opportunities to reform our long-term care system here in Georgia that you are hearing about today. And we appreciate your consideration of this information and whether and how assisted living facilities might have a fit. Just in closing, I do want to note that we used a very quasi-scientific approach. We used subjective approaches in our selection of states, particularly for the focus group of the 6 states, and that additional research may be warranted to broaden the scope to conduct a more comprehensive and empirical analysis. Those analyses might include to assess the real differences in levels of care as they are put into practice in these example similar states, to gather more qualitative feedback as not all of the 6 states responded to our outreach, and to gather more quantitative data to perform cost impact analyses on the influence on long-term care expenditures in states that reimburse for assisted living facilities versus those that don't, for example. One final comment, because I'm ever tweaking my papers, the paper you have in front of you is not going to be the most current. I made a couple of more changes, and I'm going to make sure to get Bailey the most current electronic version for you. And I'm happy to take any questions.
Thank you, Ms. Alter. That was, I'm gonna turn this down now. That was this is good information. This is, I look forward to reading this. This is a resource for all of us to look at, get an idea of what other states are doing. Oftentimes we get, good ideas from one state to the other. I do have a question for you. So, in your study, talk to me about maybe so let me first say this. So about 20 years ago, long before I was in office, I proposed a model of assisted living Medicaid, what is known in this state as ALS, specifically for memory care. It's probably 15 years ago I did that, I'd say. Is that 20? Probably 15. But at any rate, it was a separate model with a high reimbursement rate. Obviously, you have to have that to serve specific memory care individuals. But I proposed that, never got any traction, and I haven't really gone back to it. But that was an idea I had, talking about ideas way back then, that I felt like would be beneficial, because you don't have any in the entire state a specific memory care unit for Medicaid, by the way, just so everyone here is aware. So tell me what you discovered as it related to that. Did you see any things related to specifically to memory care in other states that are going on currently in this research?
I did not look at standalone memory care centers. We looked at memory care as a component of the licensed assisted living facilities in the other states. And in every case, at least in the 6, if not the 11 subset that we looked at, memory care was included. And the individuals living in those units or those wings were just as eligible for services under Medicaid as they were.
Right, but you understand my point. Your reimbursement rates, if they're the same, you can't really serve them the same. They're much more expensive to serve. So,
right.
So were there differences in then, to follow up, were there differences in reimbursement rates based on diagnosis, et cetera, something along those lines?
We did see, similar to how our nursing facility per diem is built, there were add-ons for the number of people in the facility that have dementia care or cognitive disability.
And there's rate data in this study as well for us to see. Very, very helpful. All right, any questions from the committee? Okay, seeing none, we're going to move on. Thank you very much. This is great information for us to read. We got a lot to read after today.
Very welcome.
Folks, it's just so everyone here is aware, what's most important is that everybody here on the agenda and on that list is heard today. And so that's why we're going to sit here and eat in front of you, because I don't want anybody, we have to get out on time because we have folks that have come a long way, but what's most important is we're here to do a job, and we're not going to fail at that. And so everybody knows how to step out if they need to, but we're here to go forward. Ms. Petra, who is not related to Mr. Petrie.
Thank
you for being here.
Thank you. I'm going to I've got a quick PowerPoint, so while y'all are eating, I'll figure out how I get it. This side? Okay. Lots of noise.
And while you're setting up, I'm going to go ahead and do what I was going to do later. I'm going to recognize Mr. Skin Edge. To our members, Mr. Edge represents the Senior Living Association of Georgia, a fine organization. We got some speakers here today with them, and Mr. Edge was good enough to provide lunch today. So eat more chicken, says Mr. Skin Edge.
I believe I'm almost there. All right. Let's see if I can get this back. Okay. Can y'all hear me? Great. So I'm here to, I think originally I was batting third in the lineup to set up Marcy, but I'm more than happy to go behind her and talk about why the Alzheimer's Association joined forces with Leading Age Georgia, the Georgia Council on Aging, through CoAge to sponsor, to ask for House Bill 582 to be sponsored and brought to the legislature last session, and I believe it is in Human Relations and Aging, to look at how we can allow individuals to access Medicaid services in assisted living communities, especially those that are living with Alzheimer's and dementia. Quickly, I am Nancy Petra. I am the Government Relations Director for the Alzheimer's Association, and I do just want to start with our mission. The Alzheimer's Association, we continue to try to lead the way to end Alzheimer's and all other dementia by accelerating global research, driving risk reduction and early detection, and maximizing quality and support. And in my role, I serve to be here to advocate on behalf of all of those in Georgia that are living with Alzheimer's and dementia, including their caregivers, and to work with you on policy. And so today I want to talk about how we can ensure access to Medicaid. So I'm going to start with some numbers because I know y'all haven't had enough of those thrown at you today already, but you have heard about how the population is growing, and you have a copy of our facts and figures in your packet. And so while the aging population is growing, and you've heard that, I just want to add the Alzheimer's numbers to this data. More than 6 million Americans are living with Alzheimer's, and that number is projected to nearly double by 2050. While age is a risk factor, Alzheimer's and dementia is not just a disease of old age. According to a 2021 study, an estimated 3.9 million people worldwide are living with young onset dementia, which is defined as when you start to have symptoms that emerge before the age of 65. So many people, including Mary, who you heard Kathleen talk about earlier, have early onset, and they start to get these symptoms in their 40s and 50s. They have families, they are part of our workforce, and they are caregivers sometimes when this Alzheimer's disease strikes them in their prime. And for these individuals, they may need to stop working. Depending on their financial stability, they may depend on Medicaid early. And so I just want to put a plug in I was so happy to hear the presentation on PACE today because that could help individuals with our younger onset community. So Alzheimer's in Georgia for our 65 plus population. So in 2020, more than 150,000 people were estimated to be living with Alzheimer's in Georgia. And in about a year and a half from now, by 2025, we are projecting that estimate to grow to 190,000. And so then these are just the people over the age of 65. This doesn't include the individuals we just talked about with young onset who maybe haven't hit 65. And this is almost 27% increase in the number of people over 65 that are going to be living with Alzheimer's in Georgia. I want to talk a little bit about dementia. It is, the umbrella term that covers a wide range of medical conditions, and Alzheimer's is the most diagnosed, but there are lots of others in dementia: Lewy body, vascular, frontal temporal dementia. Parkinson's sometimes has dementia symptoms. These are the symptoms of the syndromes that affects their cognitive ability, their ability to remain independent, their ability to keep working, and so this disease disease is long. These diseases can be slow and burdensome, and I'm going to talk more about that. But when we're talking about access to assisted living care and memory care, we need to keep in mind that we're not just talking about those with Alzheimer's. We're talking about individuals living with all types of dementia. So, as I said, Alzheimer's accounts for about 60 to 80% of those cases, and it is slow and burdensome progressive disease, and that people over the age of 65 typically survive about an average of 4 to 8 years after their diagnosis, but some live as long as 20 years. Individuals from age 70 to 80 with Alzheimer's dementia spend an average of 40% of this time in dementia's most severe stages. So if you're looking at the continuum that I have up there, there's the early stages where maybe you don't have any symptoms at all. There's early signs or mild cognitive impairment that's due to Alzheimer's disease, and you may still be able to work every day and live at home and drive and do all the other things that anyone else not living with mild cognitive impairment can do. And when you go into early stages, everybody's disease progression differs, but it's really where they spend most of their time in this moderate to severe stage, where they start to need more assistance with activities of daily living, or they need that constant oversight of a memory care center. And it's important to note that their level of care, they may not need 24-hour skilled care. They may not meet that level of need where they need to be in a skilled nursing facility. But maybe they don't have anyone who can keep them at home anymore, or maybe their caregiver has also started to develop chronic illnesses from doing all of the bathing and dressing and medication management or feeding that they've been trying to do. They really need this interim piece of our long-term services and supports continuum, and that is the assisted living care and memory care access. I just want to point out that according to the National Center for Assisted Living, more than 1 in 5 assisted living providers has a secure dementia care unit and only serve adults with dementia. And this is critical because an estimated 42% of the residents that are living with Alzheimer's and dementia are in assisted living communities, according to NCAL. In your packet, you do have a spreadsheet that shows the number of assisted living communities in Georgia and the number of memory care units that we have. And I just want you to know that the significant portion are memory care units that we do have that are certified in Georgia. They are in your assisted living community level, which right now is all private pay. All right, so I said a little bit of this, but just to kind of go back over, assisted living community they meet dementia where it is. They give a unique mix of all types of supportive services, help with assistance of daily activities of living, and this is really important for individuals in early stage who may not be able to stay home but don't qualify for skilled nursing care. And as I just said, more than 1 in 5, they have a secure dementia care unit. You can see from the spreadsheet in your packet how those numbers look in Georgia. So I wanted to kind of get into some granular data with you because you do have this map and one other map in your packet, I believe, also. And so on this map, this shows, well, let me back up. Sorry. Earlier this summer at the Alzheimer's Association International Conference, the first ever county-level estimates of the prevalence of people living with Alzheimer's disease across the U.S. were released. And I'm just going to tell you that the Southeast in general didn't fare very well in this survey, but in this new data release, but Dougherty County, Georgia ranked in the top 10 counties. They ranked number 7th in the United States, with the highest prevalence of people over 65 living with Alzheimer's disease. So since we're here today to talk about the need for access to Medicaid and assisted living communities and memory care as permissive, just as an option, I wanted to show you this map of where all of the small personal care homes are. So all those little circles, and I realize you can't really see the big overall state map, but we blew up Dougherty County for you. And you've got Lee and Worth County and some of the others, and you see where those are. And so Dougherty County has quite a few, kind of in the same area. And if you'll notice underneath those, that's where it's the most red. So you can see this is where Dougherty County has more people over the age of 60 living at 200% of the federal poverty level also. So according to the Georgia Department of Public Health's OASIS data map, there are more than 14,000 people in Dougherty County over the age of 65. So if the county prevalence there is 15.3%, which was what the new data released this summer said. Then you've got over 2,000 people just in Dougherty County who may need memory care or assisted living on their Alzheimer's disease journey. If you look at your long-term care provider spreadsheet, you will see that the small personal care homes across the state, I think the bed slots is like 2,267 Medicaid beds right now in those small personal care homes. That would just barely cover Dougherty County. So now I'm going to take you to a second map just to add to this that you also have in your packet. This is a similar map that shows you where all the assisted living communities and large personal care homes with more than 25 beds are available. So that same little piece of Dougherty that we've blown up for you, you've got one star, which I believe the star are the large personal care homes, and then the two little squares are your assisted living communities. So there's one square in Dougherty County. There's one star in Dougherty County, and then you've got one square kind of right there on the border at the county above. So again, you know, as Mr. Bauer said, we don't believe that offering the option for access to assisted living community providers and large personal care homes is going to suddenly open the floodgates. But just if one of those facilities there wanted to serve more of the low-income individuals living in Dougherty County who have Alzheimer's disease or some other dementia, we could serve more people in a less restrictive setting and at less cost to the Medicaid budget for Georgia. So in closing, I just want to say long-term service and support needs are growing. I think you've heard that from all the other speakers that came before me today. Just want to reemphasize that we're looking at a 27% almost projected increase in the number of individuals just over 65 with Alzheimer's in about a year and a half. And again, does not include the other types of dementia that I mentioned earlier. All of these individuals, they need access to memory care in their disease journey, or they would like to have access to memory care. And so we would like to give them that option and give that option to the providers in the large personal care homes and assisted living communities that would like to offer it. Memory care isn't affordable for most Georgians without access to it. So with that, be happy to see if anyone has any questions.
Any questions from the committee? Representative Campbell.
Thank you, Mr. Chairman. This question may not be exclusively directed to you, but it may be to the larger audience of speakers. But as we are in research mode and thinking about how to care for an increasing aging population, I'm curious to know if we've seen ideas from other states about funding, maybe withdrawals like we see for Social Security or other types of programs. We're talking about expanding the funding that we currently have, which is currently a fixed budget and not expanding. And so I'm just very eager to know if there are other states that are thinking about investing for the long term in this infrastructure, in the services, the care that we need for our seniors.
There are a number of states who have already developed a master plan on aging, knowing that the population is going to be the greatest in history because of longevity and the baby boom population. And we are making the recommendation currently. We're drafting a letter about that for Georgia. We could probably start with some of the components, but we do think in order to be prepared for these next 5 years, which we've already entered, that we could benefit from the development of a master plan on aging.
Thank you. And I'll just add that, you know, I think Marcy talked a little bit about some of the other models that are out there and how you can look at multiple funding sources. And so I think that's something that's, you know, the bill that we had sponsored and dropped last year really just talks about sort of looking at that over a year for DCH to take a look at it and see how we could do that. And I do think that we have, it'd be nice to get more data around dementia in general and Alzheimer's and sort of really know what we're facing. A lot of the facts and figures that we're able to give you come from multiple sources from CMS and Medicare and claims and payment places like that. And I'm currently serving as the Georgia Alzheimer's and Related Dementia State Plan Chair for the Advisory Council. We're very thrilled that Deke has just joined us on the advisory, and he's going to be a great add to that. But we would love to see how we could start looking at getting more data, and also to help in more ways to look at the workforce shortage, because the labor issue is also an issue for all of these providers across the continuum, and our Medicaid providers that provide our home and community-based services in the home, you need a lot of support too in terms of Medicaid rate reimbursements and things like that. So there's more to do.
Representative Cannon.
Thank you, Mr. Chair. Just want to thank you for your work. And just to clarify, are you with the national org or the state org? And then is there a month this year for the state of Georgia? I know you normally do a walk. Just curious about some of the softer parts of your work.
Yeah, thank you for that question. So, yes, I am with the Georgia chapter of the national organization, and walk season is beginning. So we have 20 walks around the state to support our fundraising efforts, to support research, and there are programs and resources that are in your community, and to continue things like support groups for caregivers and individuals living with Alzheimer's and dementia. And so you can go to our website, alz.org, and see. I know we have a walk in your area. There's 20 of them across the state. The Atlanta Walk, for those that are in the metro region, is on Saturday, November 4th. And we will be here for Alzheimer's Awareness Day on Wednesday, February 7th. So go ahead and put that in your calendar.
Very good. Thank you so much, Ms. Petra. And now we will have, there are no further questions. Mr. James Pettis is up next. Mr. Bo Lewis, you're on deck. All right.
Good afternoon, Chairman. Thank y'all very much for having us today. It's been a lot of great information shared. My name's James Pettis. I'm here on behalf of GACCP. That's the Georgia Association of Community Care Service Providers. I own the Pettis Group, and we own and operate. We are a provider. We operate 8 personal care homes out in rural Georgia. So while I don't have a case study or some data to present, my goal today is to share the realities, the processes, and the challenges that come along with operating small 15 to 24 bed personal care homes out in rural Georgia. And the slide that was just shown earlier, Southwest Georgia, Donaldsonville, Seminole County, we have a personal care home there, then Edison, Calhoun County. So our business model is out in rural Georgia. So I hope to share some of the realities, and people expand Medicaid, don't expand Medicaid, 24 beds, more, less. And I'm familiar with the Olmstead Act, but I'm not an expert. But I can tell you what it takes to operate personal care homes in rural Georgia. I have 133 beds in 7 counties. We employ around 8 to 10 people per location. Like everyone else, we'd love to hire a couple more, but it has been challenging. But I'm not sure if y'all are familiar with the Medicaid process. We hear Medicaid, what exactly does that mean? So let's say there's someone living in y'all's district who needs to be placed on Medicaid. So what do we do? I'm going to explain the process, and I'll tell you why here in just a minute. So the Medicaid process, you make a referral to a case management agency or the AAA. The AAA takes that case, they send it over to Alliant, which is a brokering, and decides whether or not it needs to be studied. If they're eligible, they call, do a needs assessment, and if it advances, then it goes back to the AAA or the case manager. And then DFACS gets involved to determine the cost share. I don't have the time today to try to explain that, but it's very, very complicated. And we're grateful for all our DFACS workers, but it is a very slow and painful process. And then it makes it back to the case management. It goes to team to see if the individual is eligible for Medicaid. Now, here we're talking about Medicaid, particularly personal care homes, of which I own several, but there are several under other programs under EDWP. It's Medicaid. There are personal care, there's private home care, adult day health, home and delivered meals. There are several things that will allow individuals to stay in their home that are already in place. So these services are available to some people of Medicaid if it's right for them and if it's the best fit. So that whole process takes about 90 days if you're lucky. So it is very, and it's with us. I've been in this business 18 years. Certainly not an expert, but we have been very, very diligent in forming great relationships. We do our best to know people. Certainly Brian, who left earlier, Miss Jill, Miss Carolyn with DCH. We know the people in the organizations and DFACs to help get things done. I'm very grateful that the individuals were able to help them navigate this process because it is very, very complex. You have to resubmit paperwork. So we take the client and we help them go all the way through that process. And then they get approved. And then they're eligible for services. They move into the personal care home and we provide care. And we think that we're done there, right? We've waited the 90 days. We've kept them in our facility and now we're able to bill. But I want to back up just for a minute and kind of explain the CCSP Medicaid rate. So someone who was on Medicaid, normally their Social Security, I'm going to define the SOURCE program. In the EDWP program, Elderly and Disabled Waiver Program, there's SOURCE and CCSP. I'll go with the SOURCE program because CCSP with that cost share is too complicated. So normally the individual receives Social Security check of around, we'll just say $800. The actual provider receives $726 for the room and board. So when someone comes into our care, we agree to accept them for $726 pending Medicaid approval. Now, once they are approved, sometimes, if it's entered correctly, we're able to go back retroactively and bill the rate of $55 a day. And while I'm on the subject of rates, Chairman Petrie, I want to thank you. You have fought hard for the increase of rates. I have been, as I said, doing this about 18 years, and when I started out, it was at $35.07 a day. And we went several years with no rate increase. And just recently, probably in the past 4 to 5 years, you and your team and committee worked very diligently for the right size of the rate, if I use the correct verbiage, to get it to $50. And then recently, it was increased by 10% to $55 a day. And that has been truly a lifeline. So thank you very much for your hard work in that area. So the rates, so we receive $55 per person per day, along with the Social Security or SSI check of around $726. So the reimbursement for a Medicaid bed is $2,433. Now, the Department of Community Health, in the manual, someone who is on Medicaid, the building, the room, has to be a minimum of 80 square feet. A double room, it's double occupancy, 2 is 160 square feet. Most of our facilities, the rooms are substantially larger than that, but oftentimes I'll look and see, I wonder why that was. But then when you start maintaining and heating and cooling, the larger the room, the more costs that are involved with that. So the reimbursement rates certainly need to be higher. In the personal care home setting, as many places, we're certainly battling labor costs, but also in the personal care home, you're providing food, and we've all know what the cost of groceries, inflation has done over the past several years. Then also energy costs, that too has gone up. Certainly repair and maintenance. I'm not sure if you've had any work done on your personal homes, had to put on a new roof or anything like that, but it is very, very expensive. So I wanted to just kind of walk through the process of Medicaid, the rates, and the process. So does anybody have any questions for me? Concerns?
I see no questions from our members.
All right, thank you, Jesse.
Thank you, Mr. Pettis. Mr. Bo Lewis. Miss Katie Ramp is on deck.
Good afternoon, Chairman and Committee. My name is Bo Lewis. I'm with Concerned Care. We are actually a ALS family model Medicaid provider. Most people are well aware of the larger facilities, even up to group home, larger personal care homes. But one of the great options we do have in the state is a family model home, which is licensed up to 6. It's in a normal residential area. It looks just like your house and my house. The reimbursement rate is the same as for some of these other facilities. It's 24-hour oversight. And the biggest thing about being in a family model home is the continuity of care. You're only, these people are in a family. You know, they can no longer live by themselves. They need help, but they don't need 24-hour medical care. So they get to move into a home that is just like my house, your house in a neighborhood. They get watchful oversight 24 hours a day, assistance with their medications. Mr. Johnson, it's time to take your medications. They get fed. They get transportation to and from medical appointments. And this is all done with 1 or 2 caregivers. They become family. And we don't have a shortage of beds. There's beds available. We have CCSP approved personal care homes in Augusta, South Georgia, and all around this Atlanta area. There are waiver beds available right now. We have homeowners that are willing to open up additional homes, because the one thing about a family model home, even though homes are getting pricey right now, they are the fastest way to scale a facility, if you want to call it a facility. It's a lot easier to purchase a home and get it permitted than it is to build a 120-bed facility. And you can do that enough to scale. But right now, we're not seeing a shortage. We have beds available. We're not seeing a waiting list on the waiver program. You know, when we refer a client, it goes, like Mr. Pettis said, sometimes it can take 90 days. You know, same process, start service, hope for it's retroactive when it comes back. If not, we've already paid our nurses to do their visits. But I just wanted to touch on a family model home, because I think a lot of people sometimes forget how big of a part of the community care waiver programs that the little mom and pop family homes actually are. You know, these people basically turn their homes over to individuals to take care of them. None of them are in it to make money, because you're not going to make money at a family model when you have 3 clients, you know. So I just want to make you guys kind of aware that, you know, we are part of this. And if you guys have any questions about a family model home. All right, thank you.
Questions? Thank you, sir. Ms. Ramp, with the Georgia Senior Living Association referenced earlier. Thank you again. Thank you for lunch, and thank you for Skin Edge. He's a great lobbyist and a friend. He's always knowledgeable of the folks he represents, and I appreciate him. Thank you.
Mr. Chairman, members of the committee, on behalf of the Georgia Senior Living Association and the senior living industry at large, thank you for your invitation today. The Georgia Senior Living Association is a nonprofit trade association that represents freestanding assisted living communities, licensed personal care homes, and retirement campuses within our state. We serve vulnerable adults in assisted living, memory care, Alzheimer's care, and other senior congregate settings. In Georgia, the senior living industry serves over 43,000 seniors with nearly 1,700 communities. In our industry, we directly support 22,000 jobs, and an additional 18,000 jobs are supported indirectly through home health programs. That number doesn't account for industry provider companies that offer goods and services to our senior living communities: landscaping, uniform services, pest control, architects, fire services. So senior living is essential. It's an essential part of our economy. In fact, in our state, senior living is responsible for over $5 billion annually. Just for reference, colleges and universities, $5 billion. The chicken industry? $5 billion. Communities are staffed by employees and administrators who are in this profession because of their deep desire to offer dignity and comfort to seniors as they age in place. The passion of those working in assisted living communities and personal care homes is second to none. We want to create a home where seniors don't just enjoy living, but where they thrive in living. As a leader in this industry, a significant challenge that we're observing is the disruption of services to our seniors due to accessibility and affordability. As costs rise, fewer seniors have access to aging place home options. It is our hope to pinpoint areas of concern and work to be part of the most efficient, effective, and lasting solutions. As you've heard from the groups today, Medicaid and assisted living will one day be part of the progress of our industry. Assisted living facilities generally provide custodial care that does not fall within the Medicaid arena. While GSLA is not opposed to Medicaid being accepted in the senior living market, we would caution this committee and those of us who are part of the research to investigate both the positive and negative consequences of any significant quick change. Recently, we've seen the effects of CMS regulations on communities in Florida. North Carolina and Virginia both talk about their often detrimental costs associated with the administrative side of the Medicaid program and the waivers in their state currently. That doesn't mean that it's bad per se. It just means we need to spend time looking at the unintended consequences, which we heard about today. We need to do a little more research. As an association, we understand the desperate need for Medicaid options for our middle and lower income Georgians. However, not to the detriment of past cost or affordability for private pay residents, or to the businesses that provide those services for residents. Even before the pandemic, assisted living communities and personal care homes began facing staffing shortages and the regulatory, operational, and cost concerns that come with staffing. According to NIC, the National Investment Center for Seniors Housing and Care, 96% of communities are facing staffing shortages. 61% of senior living communities are concerned that staffing shortages might force them to close, and 89% are concerned with the regulatory impact on consumers. All this while Georgia's 65 and older population looks to more than double in the next 10 years. Medicaid's reimbursement rates are currently too low. If Medicaid becomes an option in assisted living, and for those current personal care homes using a waiver, providers may have to minimize care options, quality of care, or ancillary items to be able to provide care at the current reimbursement rate without passing costs. We believe that a majority of residents who will take part in this Medicaid program will be there to continue the care for residents who no longer have the funds to pay for their senior living choice. However, in a broader conversation, there's cause for caution. We realize that the value of Medicaid would be brought to seniors in our state, and we would ask to move forward that as we move forward, Medicaid would be an optional payment program for assisted living communities as we have heard about today. When in perspective, GSLA hopes to protect current residents, potential seniors looking for congregate living situations, and companies that significantly impact our state economy. We look forward to continuing to work tirelessly in research to make strides in offering a safe, a dignified, and appropriate choice for our seniors to age in place. And with that, I'm open for questions.
Ms. Schramp, thank you. I want to make a comment that you mentioned something that Representative LaHood, Chairman LaHood and I discussed over the years quite a few times, and that is we have to recognize, we talked a lot today about the degree to which much of these services are paid for by Medicaid, which means by the taxpayers. And everything we do that increases cost on an industry makes it harder for people who pay themselves, which is what we want. Remember, we want people to take care of themselves. Mm-hmm. And every time we make it harder for them to do that because we increase cost, makes it more likely people are going to wind up being supported by government. Right. And so we have to be, so you alluded to that. I want to mention, you also mentioned these, so just as someone who did assisted living in the past, no longer, I sold quite a few facilities that were, 24-bed facilities, and numerous of them have closed now. Mm-hmm. and one in Pula there. I mean, talking about nice facility we built brand new, but it's now something else, and it's actually being used for a wonderful cause, serving the community, but not in assisted living, because they couldn't hire and they couldn't afford to hire. I mean, who they could hire, they couldn't afford, and so they're no more. And the one location in the county I live in, the one assisted living facility for Medicaid is gone. That was the only one we had right there in Pula. So we have to be careful. I'm sure. Listen, I don't know why they closed. It was long gone. It was sold, but it had a lot to do with staffing. From their description to me. So at any rate, those things are important, and I appreciate your comments. Chairman LaHood has some comments as well.
Yeah, just wanted to continue what Chairman Petrie was alluding to, and just further some points you made, and just that your membership is made up of private pay providers.
Correct.
There's no Medicaid reimbursement currently with the larger personal care homes and assisted living communities. And if I understand correctly, I don't think your membership is opposed to cracking the door on providing some Medicaid services, as long as it's not mandated, number one, and number two, that overburdensome regulations don't come along with the ability to provide Medicaid services.
Absolutely.
Because it seemed like every time we policymakers, lawmakers, advocates start tinkering around with rules, regulations, staffing requirements, it always drives the cost up. And we all want the same thing. We want what's best for people. We want to take good care of people. And so your membership, I think, is a great example of how to do that well, as evidenced by people are paying out of their pocket, to use these services. And it kind of trues up the cost too, because they're not going to pay it if they don't see a good value in it.
Correct.
Yeah. And so I think it's, the membership that Katie represents is probably one of the best barometers out there on what it costs, to serve people well.
Any further questions from the committee? All right, we are getting down. We're making good time now. We are now, thank you, Ms. Ramp.
Thank you.
And now, Ms. Jenny Helms with Leading Age.
Thank you, Mr. Chairman and members of the committee. I'm Jenny Helms, president of Leading Age Georgia, and we're an association that supports not-for-profit and other mission-driven organizations that provide housing for seniors as well as services. And I just absolutely love all the conversation here today, and I love that you're open to what has been brought before you. And we're a huge proponent of the quality of care being provided throughout the continuum of care, because that's what Georgians need. And several of the different programs talked about today have been established in other states. So a lot of these, it's not something new that we're just whipping up. PACE is in over 30 states. And the Medicaid and assisted living, like Marcy Alter said in this report that we commissioned, is going strong in over 11 states. 45. And 45 Medicaid and assisted living. And I do want to say that there's a paper that talks about the original purpose of the Olmstead Act, which was designed to help ensure that people living with disabilities had access to the community. And so when that case came down, Georgia came up with policies that said, we'll make sure that assisted living is not institutional by limiting it to 24 beds. But we've seen through architecture and designs that you can have communities that are not institutional in design that are bigger than 24 beds. And that's what we want for the people who don't have the money to pay the private pay rates. So that's what we're really pushing for. And I do think that you, Representative LaHood, made a great point that staffing is one of the big challenges that we had. And those of you all that know about the new CMS ruling that will increase staffing ratios know that we are going to be having an uphill battle here. The RN staffing ratio is going to be almost undoable here in Georgia because we don't have the staffing levels that they need. And yesterday there was an op-ed that the AJC published that I wrote that showed that Georgia has one of the lowest RN ratios in the country to residents in long-term in nursing homes. And so for this mandate to be put on us will be a very much a hardship. What Georgia does have is a lot of wonderful LPNs. So we've got to be looking at having a state response to the burden that's being proposed for us. And we also need to be looking at ways to fortify our staffing ratios and looking at how do we get more RNs through school, how do we advance LPNs to RNs, how do we have more clinical sites, how do we do other innovative things like Representative LaHood did with the MedTechs. So thank you.
Thank you, Ms. Helms, and I think that emphasizes something that I've tried to make sure I do since I've been here, and that is, when government makes decisions on things about industries they don't understand, it leads to a lot of unintentional consequences. So what you have to do is make sure you hear from your industries, and of course, we do that here. That's why we have so many engaged industries in long-term care, and they really know the service. They understand it better than we do, and they understand it better than advocates. They do. They understand it better than regulatory agencies. They do. They understand what it takes to provide that service. So we have to hear from them as well as all those others who are all equally important. So those are great points, well made. 26 is Representative Fry.
Thank you, Mr. Chair. We've heard a lot of talk today about the labor shortage. Can anyone actually pinpoint exactly what the issue is? Because more often than not, labor shortages would be attributed to low-paying industries. And it's also a situation where we're seeing as our corporations are maximizing their profits in the publicly traded companies are reporting the highest profits they've ever had. Is this a situation where we need to pay nurses more? I'm married to a nurse. That would be great, actually. She works like crazy in an emergency room. But, this is, everybody knows that the best way to attract workers and to keep workers is to pay them more and treat them well. So I'm not saying that that's not going on. I'm just asking, is there an answer to this question?
Terry Barcroft with Wesley Woods, and I can give our perspective, but also a scan of the industry if anybody else certainly speak up about that. I think there's a number of things going on. One is COVID did us no favors in the fact that the heavy burdened regulation that was enforced at the time, as well as just having people masking and being isolated, created an opportunity for folks to look at this industry and say, I really don't want to deal with all of this stuff that goes along with it. I think pay also really hit a high point of pain during COVID as well. We have just initiated moving our employees to a base of $15 an hour. I don't think a lot of people in this industry can do that, frankly. Not to disparage for-profits, but when we're beholden to the community and our board of directors, those funds can be diverted to the team members. But with that said, that creates in a private pay field of assisted living, those costs only go up. They can only be passed on either to the residents, their families, or to philanthropy for folks to provide us money to help offset some of those things. I think culture is another key component. Like Deke, Wesley Woods is one of the we have 2 of 5 Eden Alternative certified nursing centers in the state of Georgia with person-directed care. I think that creates a culture of high retention. Generally, nationwide, assisted living saw 56% turnover rate in their staff. In general, nonprofits are half that, and we're around 24%. So I think culture drives a good bit of that as well. So I think it's a number of things. One is trying to get people who are interested in this industry is important. To get them trained up in this industry is critical. creating culture within organizations so that people want to come to work every day. And then finally, paying them a good rate. Not only just paying them, but providing benefits as well, which cost a lot of money that gets passed on. So to echo our friends with the small homes, I think it's super hard to do what you do, and I applaud you every day on those really tiny homes. How do you build economies of scale on a reimbursement rate? So I hope I answered your question, but it's a challenge.
I'm just going to add to that too, that I think for, our small providers, our home community providers under Medicaid, all of them, the reimbursement rates are really, really low. So while they would love to be able to pay some of those direct care workers more, they cannot. They just can't. And so just to add to what Terry said too, I think creating those cultures, for people to want to do more of the heavy lifting with individuals living with Alzheimer's and dementia, which it takes more caregiving. We believe that training and education to help them be more confident and confident in that care is important. So Katie Grant, there's several of us in the provider community that we're working together right now with DCH to see if we can come up with sort of certificate program that will maybe help kind of give people those competencies and build that dignity to want to come back into this workforce, because we did lose so much of that with COVID. So if that helps any.
If you don't mind, I'd love to echo both Terry and Nancy. You have hit it spot on. And I think there's one other component, and that is understanding career pathing. We have high school students that think healthcare means I'm a doctor, and they live in rural Georgia without the opportunity to go to a technical school, let alone med school. And so I think we have a responsibility as residents of Georgia to help bring that through. We've started conversations with the Board of Regents. How do we do that at the college level? Sure, but there's an opportunity for us to offer, because it's not just nurses that are down. That number is significant and it's true, but it's our direct care worker that has maybe some of the highest stresses in a community. So I think that's part of our responsibility as associations. Absolutely, it is also our responsibility to bring that to you and say, how do we pay for a program for our high schoolers to know they can take care of people and they can grow in this path and one day become a CNA, an LPN. This could be your path when you thought college wasn't an option.
And we have the option B program, scholarship work, and Hope does cover that, but we need to do better at pushing that for our kids to go with that.
Ladies, the three of you, those were remarkably good answers, in my opinion. I think those were fantastic. And I would add one other thing from 30,000-foot view. Remember, our state is exploding with economic growth. And so opportunity has been created. We've done such a good job of creating opportunity in this state that we could, there are so many better jobs than changing adult diapers, sadly. We have to have those folks, but it's not glamorous. And so individuals have other opportunities that they pursue. And there's another thing we need to remember, again, at a 30,000-foot level, and this is a fact. We have a smaller workforce than we did 15 years ago, largely because of drug addiction and drug overdoses. We have a society that's got a multitude of problems. And so our workforce, I heard, I think you were there, we heard some data from our Director of Economic Development, and it's amazing that we have an actually smaller workforce than we did because so many people have been removed from the workforce. So at any rate, we have a few more questions. Now we are going to end at 1:30 as directed. We have one more speaker, but we're going to go ahead and go. We're going to hit these real quick. Chairman LaHood first. Okay.
Just real quick, Representative Fry, I agree with everything that was said in response to your comment about the workforce, but just want to repeat something I said earlier in this committee hearing, and that's that there's almost 500,000 direct caregivers less in the workforce today than there were pre-pandemic. And so just to reiterate what was said, a lot of those left the workforce. Some of those were long-tenured caregivers who we're not going to get back. And what we're seeing in the younger workforce is a trend towards shorter tenures. And I think to Katie's point about career pathing, that's okay. I wouldn't really expect someone to make a career, 20, 30, 40-year career out of working an hourly, CNA job, and that's all right. But if we can show them a path to starting there at a closer to entry-level pay, and then growing in that organization or in the healthcare field. We just need to get better at doing that. We need to make the certifications, easier for people to get into it to begin with, bring honor back to the profession, and just do a better job with our pipeline.
Representative Campbell.
Thank you, Mr. Chairman. I think it would be remiss of us not to also identify a significant fact that in the history of caregiving, it has been predominantly provided by women. And nurses make up at least 85% of RNs. And when you think about other care providers, it's predominantly women and often women of color. And as we think about our culture and the value and the priority of caring for one another, I think this also has to be a part of our conversation and our prioritization and making caregiving, yes, a valuable and honored career. Absolutely.
Representative Fry.
Thank you, Mr. Chair. Those answers were incredible. I appreciate everybody's input on that. And just to be clear, we need to make a decision as a state to take care of our aging population. And that decision would encompass the potential raising the reimbursement rates. Is that correct? Everybody can nod if that's correct. Okay. Just want to clarify. Thank you.
That was great. All right, we have one last person sign up, Mr. Paul Staginga. And I will be, we're going to be right on time, guys, so.
I'm going to do this.
No. Hey, we've got 15 minutes.
I don't want to stand between these nice people and lunch.
Yeah.
Okay, I had to make a bunch of notes because you guys covered so much. Really, my name is Paul Staginga. I'm an architect. I am in private practice. Our office is up in Alpharetta. I have to tell you a little bit about myself to sort of establish sort of why I'm here. I've got buildings in 42 states, from Alaska to St. Thomas. I got into long-term care and health care because I wanted to be an architect when I was 8. I lost my grandmother in a nursing home to what they call benign neglect. They cut off her one foot. A couple months later, cut off her other foot. And I realized that I wanted my architecture to be more meaningful. And you'll find other architects who are optimists and idealists, and that's what I'm here for. I'm trying to make the world better. And I so much appreciate people like Jenny who mention architecture when they talk about, what we're doing, because we're in a room, and this is architecture. So my goal is to make extraordinary buildings that support independence, dignity, the right to live and work, and home-like, you've heard that term. One of the things that I wanted to point out, which was what I had mentioned to Chairman Petrie earlier, was the fire codes, the building codes, and the zoning ordinances are tremendous obstacles to the innovation that these people are trying to do. The zoning code won't let you go into a residential area. The fire code, to answer one of your questions, the 24-bed rule is really driven by the fire code. The fire code says small buildings, small people, easier to get out. Bigger buildings, more people, harder to get out. So a lot of the number is driven by the fire code. And then, of course, don't be fooled by my youthful blonde hair, but I've been around so long. We started with 24 beds. First one was on Claremont Avenue. The exit strategy was if it didn't work, they were going to sell it to a sorority. Then we went from 24 beds, then we went to 32 beds, then we went to 48 beds. Then we went from 48 beds to 72 beds, now 90 beds, 92 beds. You start talking about companion living. I mean, everybody says, oh, single room. Well, there's a lot of companion living going on. A lot of people want to live together. They want to live with their brother, their sister, a lot of, 2 aunts. And now you're seeing 100, 125, 175 beds. And a lot of it personal opinion, is driven by the bureaucracy and the economies of scale. These companies have to get so big to be able to deal with the administrative part that you wind up, look at all the nursing homes, right? They all were started as little family-style nursing homes in the 50s. Every one of them has been sold to a big corporation. And if they haven't been sold, they've been triple, 6 times leased from that family who still owns them to the big corporation. So my purpose was just to plant the seed. As you go through this, you've got to think about the fire code, the building code, and zoning. Because if we don't change those things, we're going to be up against heads. Mr. Cato, he's got a great model. 205, there's another one in Cartersville. But in perspective, remember, he's getting 300 something, 350 a day, 30 days. He's getting almost, what is that, $6,000 a month? No, $12,000 a month. $12,000 a month. You go to private pay like the Corso at the end of West Paces Ferry or a Holbrook, private pay is $12,000 a month. They can do it because Wesley Woods is a jewel. One of my first senior projects was with the original geriatric hospital with Scott Houston, and so they're a jewel. But they're salmon. They're swimming upstream. Private pay people can't do that. Very few. Mid-market is $4,000 a month. How many of you can afford $4,000 a month? That's still a big number, right? So, fire codes, let's evaluate them. Building codes, evaluate them. Law and ordinance, the zoning, who would love to have a little tiny house in the back so mom can come live with them and not have to be institutionalized? Zoning won't allow you to do it. And so, it's going to fall on you guys because, again, I'm private pay. Nobody paid me to come here. I'm not a representative or a lobbyist. I'm just somebody that cares. And being the optimist and being the, idealist, I wanted to see what are we going to do next? Because I want to make sure that my next communities are meeting all of those needs that our fine audience has addressed. So, with that, thank you, Chairman.
Paul, that was most helpful. And back to what Chairman LaHood and I were saying earlier, everything that drives up the cost of building that facility drives up the cost of people living in that facility. And by the way, these zoning laws have a huge impact on serving our IDD population because they are zoned as small CLAs that are required, as you may be aware, for individuals with intellectual disabilities they're zoned out of most communities, which is another huge problem. All right, we got Representative Okoye has a question for you, Paul. If you can answer it from there.
It may not be a question, sir, but about the zoning, the ordinances, I really don't think those are the issues. They're not in my backyard. That's always, I served, I'm a civil engineer, by the way, so I understand what you're talking about. But I served on the planning commission for many years. We would give special use permits for personal care homes, the 4 bedrooms, 5 bedrooms. But some nights we almost get stoned just for doing that in some neighborhoods. So it's not just the ordinances. I think it's public education that we need to concentrate on. Thank you, sir.
Sure. And most of the, I'll call them developers or people who are building, they're not going to fight the year fight for a special use permit. They're going to go and buy an office institutional site, hope it's not next to a cemetery, and build their property and serve their people. And so we've got to find ways. Civil engineering took me 10 months to get a building permit in the city of Swan. Should never take that long. So when I'm done with this, it's under construction, I'm going straight to the mayor and say, can I take you to lunch? Because we gotta fix that. Because Swanee is booming, it's for an Asian community. They have, 400,000 Asians in the city of Swan. And it took us 10 months, so.
All right. Unless there's anyone else here yet, Ms. Johnson.
We do have another speaker that is with us today. She'll just take a brief
Please.
for presentation because her material is in your packet.
All right,
And
good.
that's Christy Fuller.
Ms. Fuller, let's hear from you. We're not going to leave anybody behind.
Well, thank you. I really appreciate that.
Now, I am the person between all of you and lunch, which I do not want to be either. So, Chairman Petrie and members of the committee, thank you so much for this opportunity to be here and for this conversation. It's been incredibly fruitful. Some of you know so much about this topic, more than me, but maybe on a few points I could add some additional information. And I think this is just an incredibly important and complex issue. So my name is Christy Fuller. I am an assistant project director at the Georgia Health Policy Center at Georgia State University. And my material is the 2-page kind of handout there. So as the state explores options to increase the services and the supports available to meet the needs of older adults and people with disabilities, it seems like we have an opportunity to really explore the options along the care continuum as we have discussed today. There are actually quite a few options. They are really complex, but there are a lot of options available to the state. Based on an analysis of Mathematica Policy Research did of Centers for Medicare and Medicaid Data, or CMS, in 2019, Georgia's Medicaid program provided care for 35,000, almost 36,000 individuals on the fee-for-service program and institutional settings, and almost 47,000 individuals through a 1915C waiver program. As described by Chairman Petrie, the number of Georgians that need long-term services and supports that are served in home and community-based services and settings has really grown substantially. So if we look back about 20 years ago or so, in 1986, only about 10% of Medicaid dollars were spent on home and community-based services, and now that has reached almost 50%. So we've made a lot of progress. And the change in Georgia we are also seeing that in other states. So most other states are also working in the similar kind of way that we are, putting their heads down and trying to figure out what works best for them. And we are all benefiting by flexibilities that are being offered by CMS. And then states are choosing, actions that work for them to cut and manage Medicaid costs. Thus, as the national average for expenditures on home and community-based services is at 59%, we at 50% still have some room to go here, I think, if that is part of our approach to managing costs, is to look at those home and community-based service options. So, as mentioned, this shift in the number of people receiving care in home and community-based settings has been encouraged by CMS and successful in many states. Though these expenditures are not evenly distributed across all populations served through the age, blind, and disabled population. So our numbers look pretty good, but if you look at the different populations within that, older adults and people with physical disabilities are less likely to be served in a home and community-based setting than an individual with an intellectual or developmental disability. So the Georgia Health Policy Center has served as a partner to the state to evaluate one demonstration program that was mentioned earlier, which is the Money Follows the Person program, which helps to transition individuals who are interested in leaving an institution and residing in a community. These individuals are Medicaid eligible, and they typically move with the support of one of the 1915C waivers. So we at the Health Policy Center calculated and analyzed per member per month Medicaid expenditures over time. So folks who were served in the institution who decided to move out, and to probably no one's surprise, they were able to receive a high level of care, have better quality of life, and do that at a lower cost, even 2 years out of the transition time frame. So states that have explored a variety of approaches to address rebalancing options, including those available through Medicaid, or are seeking to address alternatives that may help support individuals before they become Medicaid eligible. As Brian and Marcy described, individuals who meet the eligibility criteria will qualify for care in an institution. It is an entitlement benefit, and it is very difficult to manage the costs on that side of the equation, which is why many states are exploring these options for home and community-based services. There are a lot of Medicaid authorities, which are fairly detailed, and I don't proclaim to be an expert on all of these, but I do just kind of raise them because we haven't talked about them today explicitly, but there are authorities like 1915I, 1915J, 1915K. There are other demonstration waivers, 1115 demonstration waivers that can be utilized, and then programs like we have talked about, and integrated care options like PACE, accountable care organizations, and integrated care for dually eligible Medicaid and Medicare beneficiaries. So in addition to those, state plan benefits can include home and community-based services and be utilized to develop tailored benefits for those target populations, some that we may want to help avoid institutional care in the first place. So as an example, Vermont, which is definitely not like Georgia in many ways, but is a good kind of comparison, received authorization through a Medicaid 1115 demonstration waiver to provide limited home and community-based services for adults at risk for nursing home admission who may not be eligible for Medicaid and do not yet meet the nursing facility level of care but are anticipated to. So they could provide services like adult day, homemaker services, and flexible services that were directed by the consumer. And the goal just really being to avoid that more costly nursing facility care and avoiding that the loss of one's home. And that's something that we've seen with Money Follows the Person. Once someone goes to a facility, it's a lot harder to get back out and reestablished in the community as you think about deposits and furniture and all the basic needs that one might have in that situation. So ultimately, just really quick, a takeaway is that there are a lot of options available for consideration, many which have been tested in other states and could be explored by us as well, and I look forward to following how the work unfolds, and thank you for squeezing me in here at the last minute.
Those were very helpful comments. Perfect time. It is now 1:29, and so, hey, somebody going to say good job? Move to adjourn. Hey, this was good information, guys, and we got a lot of homework here. This was very helpful. I hope we'll all use it. Let's come up with ideas. Let's learn. Let's be watching pace. Let's see what the department. Let's stay engaged with the department and learn what they discover. Thank you for your diligent attention. Thanks to all of you for being here. We are adjourned.